Good evening to India and good afternoon to Thanasis in Europe and good morning to Hudson in South America. So we welcome to the part two of our international potpourri of ophthalmic trauma. I wanted to say the differences. Ocular trauma is only to the eyeball and ophthalmic trauma is to the orbit of the in the face. So we had an oculoplastic surgeon and we had pediatric surgeons, cornea, iris, everything. We miss our friend Cesare Forlini, who was doing pole to pole, right from cornea to optic nerve in the back. And now we have different surgeons doing different things. And I'm happy now. I'll share my screen for a few seconds to introduce my best friend. I think he's my, I don't want to call the long-time friend. I don't want to use the other word. He's a Athanasius Necrolopoulos, and we call him Thanasis. And he is my very long-time friend because we both went to the similar school. That is Dr. Elja Jovanovic. In that time, he was in Rotterdam. Later in Antwerp. Now he's living in Montenegro. He's retired. But we all learned a lot of tricks from Dr. Elja Jovanovic, even though we had our individual mentors. But we learned the transition of advanced vitreous surgery from Raja Jovanovic. And I think we take this opportunity to salute him. At the same time, remember our good friend, Dr. Cesare Forlini, who's one of the pioneers in vitreous surgery. We all same age group, and we work together, train together, and now we have Dr. Necrolopoulos. He started the actually the Thessaloniki Vitreous School, and I remember the similar like now we have Corona. He invited me for the Greece Vitreous School, and at that time I think the volcano erupted in Iceland, and I couldn't travel, and so it was a loss to me only, and I missed the traveling. But I'm happy we have now the webinars to do. And he's a great teacher, and he loves to teach what he knows, and he's a faculty in ISASO. He's a CEOS member, and he's a visiting professor in Toronto. And we also have another great guy. Somehow I missed calling him David Peleus from Buenos Aires, who made both me and Professor Thanas is a visiting professor in Marbonoid University in Buenos Aires, and he lives in Thessaloniki. He always has an open invitation for all of us to have he says, I'll give you a boat and an island, but rest is yours. Now, all yours, Thanasis. And you're our keynote speaker.
I just have a bit of a problem. I tried to make a snap picture of you, and everything disappeared from my. Now I'm back. So okay. I have a screen. Am I beginning my presentations, or
yes,
somebody else is starting?
No, yeah, you are. Yeah, I think. Yeah, it's already starting. Is it the correct video?
Okay, I can see that.
Yes.
Well, you don't need the voice if I can speak over, but yes. I had a voice video, and so you can mute the voice of the video, and I can talk to you. It's a very curious situation when you have a boy who was driving a motorcycle, had a road accident, and he has hit his head, and he was in coma for 6 months. After waking up from this coma, we found out in one eye he had a retinal detachment, but it was a very curious retinal detachment because we thought that for such a long time, a contusion retinal detachment would have other characteristics. We searched for the eye, and we found that he had a small tear at the periphery. You can see it in the cryo. We did some cryo to show you where exactly the port with tear is, but it was not so well established that this tiny tear would do such a damage to the eye. But if you look at the inside the eye, you can see a flat retina, almost flat after 6 months, with a lot of subretinal strands, a lot of subretinal proliferation. So we tried to put a buckle using the illumination pipe, as we do now, without the indirect ophthalmoscope. We use a 360 buckle, sponge buckle, in order to remove some of the traction for the whole thing. And now we did some vitrectomy at the end, and we found out that And we tried to see how is the vitreous, and we cataloged the vitreous. We did some catalog inside the vitreous, and you can see the subretinal strands behind it. And we tried to remove the vitreous. After 6 months, the vitreous was attached. It's incredible. It was completely attached to the posterior cortical vitreous was attached. And as soon as we move this very tough and strong vitreous, you can see that the retina started to move. And then we found out that the vitreous was giving this funny situation. And so we had to remove the subretinal strands. We use 27 gauge now. So under air, we make a small opening, not so small, of course. And then we try to remove the subretinal strands in order to put it back in place. In these cases, we try to use air, because through air, you can see all the traction areas that they are, because you have a different level with air and traction, and you can detect the traction, and also you can keep the retina back while you're removing the strands, and you can see it here. Of course, at the end, we used to use silicone oil for these cases, and we use 5,700 silicone oil by Goider. I'm not just publishing that, but to tell you that this silicone now, it's not so difficult to get it in, especially with a constellation, because we're using something like 60 psi or 70 psi while having the effusion in 20 or 30 at the same time. So the eye can be filled in 5 minutes. And also this kind of silicone can stay trauma cases for years without producing any emulsification. This is my experience. So the whole idea of this is that a contusion damage that can produce a retina detachment such a long time, it can be so different. The vitreous is so different in young people that it makes you see how things are happening. My next presentation, it's something also contusion, and I involved also my dearest friend Cesare in this one. It's a presentation that I want to make when I come to this kind of audience. You know that chopping wood, it's the number one reason for dropping a lens into the vitreous.
Rahul, next slide.
Get the next slide, please. Yes.
Rahul, next slide.
And this is the famous Cesare Forlini, our great friend, and I miss him every day more. And he's just inside the eye. And this is a beautiful picture I have, and I show it in every meeting, because I want to have his company all the time. And I'm sure Nati is doing the same. So next slide, please. Well, yes, you know, trauma and subluxation is the thing that they drop down. And next. Is it possible to switch the slides myself? Okay, you do it perfectly nice. Another issue that I have to address is that ultrasonic energy is not retina friendly. So people that they're thinking of removing this dropped nucleus or lenses using the intraocular force of ultrasonic have to bear in mind that it's not, as they say in this paper, so friendly. Next, please. And we made a technique, we call it Bimanual soft, B-soft technique, in all around less traumatic for lens complication. And that is removing the drop lens without using any energy, without using the intraocular fragmental, placing a non-sutured endoscleral lens at the end. You need, next one, please. You need to have for this a 23 gauge vitrectomy. 25 doesn't work, at least. And 23 gauge forceps held by the guiding hand. This is the issue. This is the thing that I'm telling everybody. You have to use the forceps heading with your hand that you're working, actually, not using the vitrectomy in the right hand and the forceps in the left hand. Of course, you need a chandelier illumination. And of course, you need a wide angle non-contact, and we're using the ABUS 2 observation system, who give us 120 degrees beautiful view, so we can see all the droplets and everything. Next. So holding the right hand forceps and the left hand holding the nucleus in the middle of the eye by using 650 suction. And that's what the left hand is doing, except eating the lens, we're using suction to lift it. So first we lift it in the middle, and then we crush the center of the eye with nucleus using 200 cuts or 300 cuts per minute in order to leave the port as long open as possible. The very important thing, next one please. The most important thing in this technique is, stop it for a minute. The most important thing in this technique is don't get any pieces or anything from the surface of the retina. You have to lift it first and then grab it, catch it, even if it's an IOL, even if it's a nucleus, whatever. You cannot know how much pressure you access when you try to cut something that's on the retina. So in everything that's dropped on the retina, we first use suction. We first lift it in the middle, and then we try to do whatever we want to do in the middle of the eye. Here you can see that we have a guy that's 65 years old and had a very difficult trauma because he was chopping wood, and the wood hit him in the face, and he had a mature cataract dropped inside his eye. So the first thing to do is to remove all the traction around all the vitreous around the dropped lens. And you can see it's a white lens, a cataract lens. It's supposed to be hard, and we remove every bit because we don't want to have any traction to the retina. So it's a complete vitrectomy. And then we go with the right hand holding the 23 gauge forceps, and then we suck the nucleus. Of course, you see we use Canalicular to remove all the vitreous. And then we hold it with the left hand with a vacuum, and we try to make smaller pieces using the right hand, which is the best hand to use to cut the lens into small pieces. This way we can use the suction and the cutting. And you can see slowly we make it small cuts. We make small cuts and we try to remove this very, very difficult but not so hard as you think. But you can see I make it slower, and you can see I never touch anything. And pieces of lens, they hit the retina, they go back and forth, but there's no problem to the retina. You can see no hemorrhage, no nothing. And the main idea is not to touch anything on the surface. And of course, if you see, we never use perfluorocarbon as a protective, and I can explain that later. At the end, you will see another thing about the vitreous. Well, removing everything, you see that the vitreous is still in 65-year-old person with the blow thing. Because of the inflammation, the cortical vitreous is attached. The cortical vitreous is attached still, and if you leave it there, you might have a macular pocket at the end. And this is because of the impact of inflammation. You might have some cortical vitreous. So you have to take care of this, and you have to remove it at the end if you want to have a safe surgery. At the end, you have a very beautiful eye with no energy on top, no hemorrhages, no tears, no nothing. As long as you use your right hand to hold it and your suction with the left hand and do all the cutting in the middle of the eye. And don't care about hitting the retina with small droplets that they fall down, but don't go for them. Don't go and grasp anything that's sitting on the retina. This is my take-home message. Everything should be lifted by flute needle, by forceps, by suction. Get in the middle, and then you can work in the middle, because now you're an expert surgeon and you have very nice instruments, and you have this able system, which is incredible. At the end, we use a system that can be used by everybody and not to very specific cataract surgeons or very experienced ones. We use 180, and we used to stop the eye in two sides, 180 degrees, one side from the other, with just a stiletto, like we used to make a hole when we do 20 gauge surgery. And then we're injecting with one hand. Of course, we use chandelier light, as I told you. Injecting with a 3-piece lens with one hand, while holding with your forceps with the other hand. And let me tell you why I make such a big hole for the sclera. This is in order, because all these systems, all these lenses are not meant to be intrascleral. So they have very, very fragile haptics, and they can bend and they can break. So if you have a big opening to take them out, you don't have so much problem of removing, as you can see here, you're moving them out without bending them, without cutting them, without making mechanical damage, because if you get them from a hole of 20 gauge, you're not afraid. After doing more than 150 cases, like that, from my fellows and from inexperienced surgeons, we use this famous handshake technique for the other haptic. So we grasp one haptic with one hand, and then we take out the other haptic with the other hand. We found out that we shouldn't use to make a scleral flap beforehand, and we make a scleral flap when you have the lens outside. And the reason is, or sometimes you have to guide the lens in the middle, because you might take a little bit more from one side, a little bit less from the other side. So like changing a wheel, you take one haptic and the other haptic, and you put it in the center of the eye. And sometimes you have more haptic from one hand and less haptic from the other hand, because you never calculate 100 degrees, 100 time what you're doing. So you can see now we center the eye, but we have different haptic length on the surface of the sclera. I'm sorry, with the same stiletto now, we go exactly where the haptic is, and we make a small pocket, just enough to get the edge of the haptic, to get it inside. And when we get it inside, that's enough. So we don't need to have the whole haptic in a pocket, but we know exactly where to switch the pocket. Don't know if we have a problem with it's frozen. The view is frozen for me. Do you hear me? Is everything okay? The video has stopped.
Rahul?
I think I saw what I had to show you. Can we go to the next slide? If you have another slide.
Yeah. Rahul?
Get the video. Go to the next slide. Well, to the next slide. Go down to the next slide, not the video. Okay. We did 155 cases. With a UBM, you know that intrascleral lenses have this benefit. They have the least astigmatism that you have for a secondary plate. Next one. The first stage of this kind of lenses. Right. Next slide. And the haptics seem very comfortable because we suture only the sclera like we did in 20 gauge, not the sclera or the opening of the sclera like we did in the 20 gauge before the 25 trocar times, which is not so big for the eye. And next one. And this technique, this is the first week. And this technique is very easy for somebody who's not so experienced with anything. Get some practical things. Next one. Next, please. Next. Only the good ones I'm showing you, not the bad disasters that we had. Okay, we show you only the good cases. Next one. And this is the thing that we talked with Nataraja before, Professor, that we have a school in Greece. Teach hands-on, and Professor Nataraja is one of the great guys. You can see Bandello here. We have all the microscopes and 3D cases and everything, and we train our fellow surgeons, 30 people each year, in a beautiful surrounding in the Salonique. Next slide, please. And of course, with the coronavirus issue, now we have to train people with the bionico eyes. Everybody should remember bionico with a K. If you want to get trained people, if you want to train your people during the coronavirus, this is the best artificial eye you can use. And we use them in the school, and we have all these 3D sessions that we do there. We learn them how to change from 2D to 3D. Next one. And this is the nightlife of Thessaloniki that I invite you all to come. Even if you have coronavirus, we don't care. Just bring the money, okay? Thank you. That's it.
So great analysis. And we have Dr. Santosh Mahapatra, who was trained in Mumbai, and Dr. Alok Sen is in Chitrakoot. And anybody else, can you comments on? And Jayant Kuha is there from Delhi, vitreoretinal surgeons in the group, and Mehul Shah. Can you comment?
Yeah, sir. This is Dr.
Yes,
Guha.
sir.
Can I have
Yes.
So,
Yes, Jayant.
yeah, thanks, sir. But I think I can't start my. Am I visible on the screen? I don't think so. Somebody has muted me.
No, we can hear you.
I think the host has to put me on the screen, because when I am clicking, you cannot start your video because the host has stopped it. Rahul, can you help me?
Rahul Raman, can you just help him in the video?
Yeah, I stopped my screen also. Please share his screen again.
No, not share. He only wants to his own video is not.
Start video. Start video.
Yeah.
It's not happening, Rahul.
Start video is not happening. And
Well,
the
you
message
can ask
says,
question now.
Okay, no problem. May I share screen? Okay.
No, not sharing. Okay. Right. Santosh, you have any comments on Dr. Thanasis?
Yes, excellent presentation, sir. I just have to tell that after 6 months of the patient in ICU, he was complaining some visual loss in the eye. You operated, or just a on routine checkup you find out that the retina is detached.
Present, sir. Present, sir.
Yeah.
Sir. Will I ask a doubt?
Okay, sir. Hello.
Sir.
Yeah.
Sir, one thing I would like to. Sir, this is the gold standard teaching. While you actually while you deal with any membranes, either subretinal or epiretinal, whatever it is, one should not do under air. But what Dr. Thanasis has said that actually he did whole under air. What comments he will do?
What under air?
He did all these membranes removal under air actually. But the standard treatment, standard teaching is ideally one should do under irrigation. One should not attempt in under air. What do you say?
He is asking about you did membrane peeling under air.
No, I didn't do the membrane peeling under air. I did the membrane peeling in the fluids completely as I can. When I fix the cortical vitreous, removing it, and I have a free retina, then I make the retinotomy. And the retinotomy was floating to my forceps when I was trying to grasp something behind the retina. So I'm using the air to hold the retina back in order to be able to get access to the subretinal strands. And the other issue is that at the periphery, when you can see, if you see a black line between air and vitreous, you can see if you miss some vitreous at the end. That's the only two. I'm sure that you are the famous Portada told me sometimes that you should not use under air because you put the pressure, you see the retinal membrane. That's why I agree with the doctor before that he told me we don't do it under air. We do it under fluid, and we use the air only for this specific situation.
Sir. Another issue is for the second case, you showed you removed the vitreous after removal the lens. But ideally,
no, you didn't see the
video. Sir, the PVD induction, everything.
Yeah. We remove all the vitreous. We remove all the vitreous before the lens. But the cortical vitreous, only the cortical vitreous, it was stayed there, and it doesn't involve with the traction. Cortical vitreous in the macula is not involved with traction. We remove the vitreous completely, not to have any traction to the periphery.
Yes, that is what actually.
But cortical vitreous, I just show it to you. You remove it at the end because you want to have a complete removal of vitreous. You want to have a eye that will not go to the factory.
Can I say something, sir?
Okay,
yes,
Dr. Mehul. After that, Alok wants to ask something. Okay, Mehul. Yes,
right.
Mehul.
In fact, this endoscleral lens we have developed as a patented product in our country, and that is being marketed now. The same type of design, little different design is there. That we fix it up on the sclera. I think we have done more than 100 lenses till now. having a great result.
Which company is making it?
Omni is making.
Okay, so Thanasis, he has designed a lens.
Yeah,
lens.
That's a good thing. Also, Carlevale from Italy has made a lens specially made for this, which we're using it now. But that is if you don't have this, and if you have a three-piece lens that everybody has, and if you're not you're not Nataraja yourself, and you're just an ordinary surgeon, we made a technique that is for everybody, and it's applicable. And if you find yourself in difficulties, you don't have instrumentation, or you don't have the specialists, you can use this technique, and the difference is that you're using a bigger opening. That's all.
Dr. Alok?
Yeah, sir. Excellent two videos, sir. I just have one query. Is in the first case, why did you prefer doing a vitrectomy over scleral buckle? Because I thought scleral buckle would be also an option for that case.
Yes, but we thought so in the beginning. I hear somebody. We thought so. We always put this buckle after Aurelio Zivonovich told us that in subretinal strands in young people, if you can reduce that traction on the subretinal strands, you might get away with it. But at the end, when we stole the eye and we had to remove the vitreous, we found out that we had to remove the strands also. So it was a step-by-step situation that we did the buckle, it didn't work. We had to go to vitrectomy, it didn't work. We have to go to cortical removal, it didn't work. We have to open the eye, the subretinal strands, and remove them by traction there. So it's a step-by-step, but it was a surprise for us. And we want to transfer this surprise that a young guy with a attached vitreous, it doesn't matter what is happening, the vitreous is playing an important role, the retinal detachment. It's not like the old guys like us, that we had no vitreous or liquefied or anything. It's so jelly and so tough that it can hold the retina back. He had all the procedure done at the back of the eye. They have multiple strands at the back of the eye. But in the front of the eye, he should have a PVR. If me or Nataraja had this, no, Nataraja is 20 years younger, of course. If me and had this situation, we'd have a PVR. And this guy did not have it. He had subretinal strands. It's so different to be young and have this contusion. And the contusion are taken granted very easily. You just shake your head. No, you should take it more seriously and check all the patients. It's a surprise for me. That's what I wanted to say.
And thank you, Thanasis.
Thank you.
Thanasis also is a pioneer using the 3D vitreous surgery for long. And Thanasis will be happy to know that I'm also now I'm using the other one, RTO, from Zeiss, and no financial interest on 3D.
One question, just one question. Can I use your Zeiss 3D in my Miller-Wedel microscope?
In your?
In my microscope. You have to buy the microscope, and only the Indians are rich enough to do that change, to buy the whole thing. The Greek ones, we have the Hera microscope, and we get the Ingenuity, which is separate from the microscope. It's much cheaper. And they asked me to do in 2016, we started 3D. But they gave me the first 3D in Europe because I was a 3D person.
Yes.
If you see me, I'm 100 kilograms, so I'm a 3D guy.
Yes.
You are so thin. Why are they used to you as a 3D? You got 1D. You shouldn't use that. But thank you. You get better.
I hope you'll enjoy the rest of the webinar with us. And Hudson has put a reference for Biome. I wanted to say Biome was introduced in 1987 by Michael Spitzner, and I think I'm one of the earliest to start using Biome from 90. Your daughter there, hi to her.
This is my daughter.
Yeah.
This is make me young again.
Yes, that's good.
Thank you.
Yes.
One interesting thing, Natarajan, about the Biome is that I don't actually use the biome. I prefer the contact systems. But this study was made with a biome. Guess what? You won't believe it. The biome contact. There is no biome. Actually, there is no biome contact, but we used the biome with a contact lens. And we tested. We could see the overall view from the retina. Of course, it's not very good view, but it didn't go on. And I met the son of the biome creator in San Diego in the American Congress there, American Society of Retina Specialists, and he said, there is no way, how could you have used the biome contact, you know? There is no biome contact, but we tested into this article, and I will translate later for you.
Okay, thank you. So the next, I think we have Dr. Das, who's the president of Orissa State Ophthalmological Society, to introduce our next speaker is Dr. Santosh Mahapatra. Dr. Das? Dr. Das, is he there? Dr. Subudhi? Dr. Sabesaji?
So he's there.
Yeah. Yeah. Okay, he's there. Right.
Visaji sir, you can do.
Dr. Das?
Contact you can do.
Hello.
He is not.
Doctor, he is sharing the screen, but I don't.
No, he's speaking as well, sir, but he's muted. Admin, can you please unmute him?
No, but he unmute, I think. Dr. Das, can anybody call him on the phone and tell him? Santosh, can you call him? Or Dr. Sabesaji?
I think.
Sir, Dr. Das is already unmuted, but I think that he can't hear us.
Oh. So, anyhow, Dr. Santosh Mahapatra is actually trained as a vitreoretinal surgeon from Mumbai, and he's actually now working in Rotary Eye Hospital in Cuttack. He's a great surgeon, and I think in the Rotary Hospital he's doing several hundred surgeries a week, and I think he's also training fellows now, and I'm happy to introduce, and he was the organizing secretary of the last year, the Orissa State Ophthalmic Conference, and we present you Dr. Santosh now. And Santosh, you can start your presentation.
Yes, sir.
He has to unshare, no?
He has to stop sharing.
Rahul, can you stop share?
Yeah.
Yeah, I did.
Yes, Santosh, you can start.
Yes, sir.
I can see Dr. Sarah there from Morocco. You're the next speaker.
Yes.
Santosh, are you able to share?
So you minimize the chest.
Santosh, any problem?
I think there's something happening from there. To share your computer audio, please install audio device to something. Please revert your audio set. Can you see the screen now?
Yes, yes.
Yeah, yeah.
Yes, now
Yes.
we are.
Okay.
Yes.
I make it full screen.
Good afternoon, everybody. I have a very simple video to present to you all, because this is, I thought everybody, general surgeons are here, and everyone is likely to see such patients with traumatic scleral tear, which is going to present to everybody. So I'll just like to discuss the principle and show a 3-minute video to go how to go about the scleral tear. One should start anteriorly dissecting the episclera away from the scleral wound and identify the exact plane of dissection and identify the edges of the laceration. This is the most important step, because sometimes the tear is not visible. So you have to do a thorough exploration after tagging each and every muscle if it is possible. If the globe is too soft, you may not go on chasing the muscles to tag all the muscles, but do at least 1 or 2 muscle tagging and go on dissecting the most suspected area where you can dissect the episclera and try to see the wound margins. Once you see the wound margins, go on putting the suture, unlike the anterior segment surgeons who have to oppose from limbus to limbus. Here you once see the wound margins, you need to start suturing. So it is called you close as you go manner. So during this closure, hemostasis should be meticulous so that the edges can be well identified. If laceration is underneath the muscle sometimes need to be inserted, but most of the time you need to drag the muscle to one side and try to see, because once you disinsert the muscle, again you have to resuture it at the insertion site. I'll show this in this video how I have dragged the muscle and repaired the sclera beneath the muscle insertion. And irrespective of perception of light, as my mentor Dr. Natarajan was telling about morning presentation, irrespective of perception of light, you have to go for the repair, and it is sooner the better. Once you see the patient the same day, you have to go to the operation theater and do the repair. And if it is a wound which is involving multiple areas of the eye, then you have to do a corneoscleral lead in that order. So the principle of repair includes look for the integrity of the globe first. If it is not, try to identify the area of retinal scleral tear. Do a 360-degree peritomy, tag the muscle, clear the subconjunctival soft tissue and tendon space, identify the scleral margin, identify anatomy and apply vital stitches. Then complete the repair. Don't disturb the clots in the SE. Test for integrity of the globe at the end of the repair. Inject air or normal saline and confirm the integrity of the globe at the end of the suturing and reposition the conjunctiva. With that, I'd would go to the video to show a sample case. Is my screen visible?
No, video is not visible.
Yes.
Rahul, can you play the video for me?
Rahul?
Rahul number 19.
Yes. This is a occult scleral tear. Nothing was visible from outside. The AC is full of blood, and then I have started tagging the muscle. And after tagging the muscle, I cleared the episcleral tissue. And when I saw the scleral wounds, the margins are well cleared, and started suturing as I told in the discussion. with once I see the globe. You can see the scleral tear extending beyond the screen which is showing beyond the muscle insertion sites in the temporal side. This is a left eye, and this is the superior rectus muscle which I have already tagged. And once you put the first suture, go to the next and go on putting the interrupted sutures, which I am doing with this 60 Vicryl sutures. Then you see this muscle was not tagged initially because the globe was too soft and I was expecting a long tear. When I approached, I gently tagged the muscle. Now I identified the tear which is just sitting below the temporal rectus muscle, and end of the scleral tear is now identified, and I'm putting the suture at the edge of the tear. The tear is extending here parallel to the limbus, but this part of the tear is just below the lateral rectus in a perpendicular manner to the initial scleral tear. So all the tissues need to be dissected, and all the margins of the sclera need to be well identified and cleared, and then you go on putting sutures one by one, securing it, and the wound should be airtight. So after making the complete suturing of the sclera, you have to check for the integrity of the globe and reform the globe with either air or normal saline or SF6 according to your preference. I usually close it with I usually inject air, and after again checking the integrity, you have to reoppose the conjunctiva at the limbus by putting 80 Vicryl sutures. At the end, the eye is looking quite good, but you see the clots in the AC are not removed knowingly because it may rebleed. So if the sclera is also showing vitreous prolapse, you need to do a primary vitrectomy in these cases also. Thank you.
Thank you, Santosh.
Nadi sir, can I make a comment?
Yes, Guha. Yeah, yes, Jen. Yes, go ahead, Guha. Yes, go ahead. You can make a comment. Can you hear?
Yeah, thanks.
Yeah.
So for this scleral tear repair, a wonderful video was shown by Dr. Santosh. Can you hear me?
Yes.
We can hear you. We are able to hear you.
I think it's critical. Can you hear me, sir?
Yes. We can hear you. Yeah, we can hear you.
Can you hear me?
Yes.
Yeah. Fantastic. So it's critical to find the posterior extent of the tear.
Yes.
Number one. Number two, I want the views of the panelists also. I would have cryoed the edges of the tear, the posterior edges of the tear, mandatorily. And another good technique that I sometimes employ is that, can you hear me?
Yes, we can hear you. Go ahead. Yes, go ahead.
Can you hear me, sir?
Yes, we are able to hear you.
Yes, Dr. Guha.
The net connection.
You can go ahead. Dr. Guha, you can go ahead.
Dr. Guha, sir, please remove the headphone. There are a problem in your headphone. Please remove the
Lakshmi,
headphone.
can you hear me?
Yes.
Yeah, we
yes,
can
sir,
hear you properly.
sir.
Sir, remove the headphone, sir.
So anyhow, I think he's not hearing us.
The third point that I was making, that sometimes when the media.
Sir, you can comment.
Yeah, I have removed the headphone. Now everyone can hear me?
Yes, Ken.
No,
Yes,
I can
Guha.
hear you. I heard Rahul asking me to remove the headphone.
Yes. You can speak now. You can speak now.
Am I audible?
Yes.
Very much.
Please see the chat also.
Okay.
You see the chat.
So Yeah, so I was asking, Nati sir, would you also have cryoed the posterior extent? Would you also have cryoed the posterior extent of the tear?
No, generally I don't do
Yes.
cryo and primary repair. Only thing
No.
I like to add, Dr. Jovanovic suggests
So would you have
invagination of the two edges.
cryoed the posterior extent of the tear?
No.
Because I would have. And
No,
third point is that when the media is clear, the anterior chamber is clear, then I usually use a right.
Dr. Subudhi, can you hear?
Can I speak?
Sir, Dr. Mukherjee, sir. Yes, please.
I think Dr. Santosh has shown very nicely the repair of the scleral tear. But normally, what happens because of the retraction of the scleral tissue, sometimes the scleral is difficult to suture, particularly when there is a abscess from the internal side. So one observation that I wanted to make. Second point is that there is this loss of scleral tissue. On those situations, the problem becomes much more difficult unless you put a scleral backdraft over there.
Yes.
Third point is that whenever it is associated with some muscle tear, as he pointed out, that muscle tear or the muscle involvement, on those situations, the repair of the scleral tear becomes much more difficult. And fourth point is that if there is a scleral tissue, if the scleral rupture is going underneath the muscle, then you'll have to detach and that you'll have to define those scleral area, and finally you'll have to oppose those areas. And fifth point is most important point: never sacrifice sclera from the surface. Whatever excess is there, unless it is ragged or infected, don't sacrifice. And even if there is no pain in the eye, that eye has to be salvaged and to maintain the integrity of the eyeball, must suture that eye. So that if there is a chance, at least you will have a non-seeing eye, which is cosmetically, that will be better than none. Thank you.
Thank you, Dr. Mukherjee. And for the evening faculty, Dr. Mukherjee is President of Ocular Trauma Society of India, and Ocular Trauma Society of India is celebrating 25th year this year, and we have every month a theme-based international webinar. Yesterday we had the advocacy and blunt trauma. And next month it's going to be sports trauma, right, sir? And domestic trauma. Yeah. So with this, I will now introduce the next. Thank you, Santosh, for the showing the basics is important. I only want to say that I learned from Dr. Jovanovic that you should imaginate the layers of the sclera like this, so that the edges are not sutured like that, so that you don't have the intraocular contents incarcerated in the scleral wound, so that retina or vitreous is not into the suture. So I think.
And also, sir, to explore the scleral wound, the posterior margin of the scleral wound better, we can also use the hands, the two arms of the scleral, the part which you've already sutured. They can also be used to traction. They can also be used to rotate the globe, sometimes with the motion, sometimes against the motion, for better exploration. This is called the hand over the hand technique. That also comes in very handy at times.
Yes. Another technique is there. If there is a loss of scleral tissue, one can have the lamellar scleral dissection from the side, and then it can be overlapped onto the other part, and then the scleral rupture can be repaired.
Very good point.
So there are many options to salvage this sclera.
Many options.
Okay. So now I will share the screen and introduce the next speaker. So the next speaker is one of the young faculty from Morocco, Dr. Sarah Idmane. She is ophthalmologist specializing in cataract and refractive surgery, professor at International University of Casablanca, Morocco. And I think everybody, I'm happy I visited Casablanca and Marrakesh. And she is the General Secretary of Young Ophthalmologists of Morocco. She has the last publication of the year in congenital glaucoma, epidemiological, clinical, and therapeutic aspects in 414 eyes. And he also is published on medulla epithelioma. Now, Dr. Sarah, you can present. I'm I'm stopping my screen share. Dr. Sarah?
Yes.
Yes, and hi. Good evening. Good afternoon to you.
Good afternoon. Yeah. First of all, I would like to thank OSOS and also Professor Natarajan for the invitation. Can you see my screen?
Yes.
Great. Thank you also for all the techniques, brilliant techniques. I'm sure that you will have a lot of follow in India and also in Greece, I think. So thank you so much. About my presentation, I will present with you a study about traumatic hyphema in children. So the hyphema is a presence of blood in the anterior chamber. It occurs after post-contusive or perforating eye trauma. And in this study, we are only dealing with post-contusive traumatic hyphemas. It's a study for the epidemiological profile of post-contusive hyphemas. It's a retrospective studies of between January 2017 and October 2019, and it was in the Department of Pediatric Ophthalmology in Casablanca. The middle age was 9.5 years old, with extremes between 4 and 15 years old, and half of our patients has more than 6 years old. Like 67% was boys versus 33% for girls. The reason for consultations was decrease in visual acuity in 49%. We had also pain and eye, like red eye in 23%. The circumstances of trauma was mainly a stone throw in 65%, and on 35% it was about some children games. The consultation, the time before consultation was 32 hours, and with a maximum delay of 12 days. In the first examination, initial visual acuity was very low. In 38% of our patients, the most frequent stage of hyphema was the second stage, about the half of our patients. Hopefully, we had just 6% of our patients that had a fourth stage of hyphema. So here we have some pictures that we took of our children with the traumatic hyphema. The intraocular pressure was high in 34% of our patients, and we had some associated lesions of anterior segments. The most frequent one was the traumatic cataract, on more than half, subluxation of lens, and iridodialysis. Here we can see a picture of a girl that she came with a luxation of lens. Here we have the aspect of angle recession with ocular hypertension, and here iridodialysis on superior. The lesions of posterior segments was most common retinal ischemia on 9%, intravitreous hemorrhage, and Berlin edema in 3 patients. The evolutions was favorable, about a spontaneous resorption of 19%, with an average time in 5 days, and the extremes till 15 days. A surgical treatment was performed just in 10% of our patients. The treatment was based on a strict rest, abundant drinks, some eye drops, steroidal anti-inflammatory, and atropine. Of course, hypotonizing treatment in case of hypertension, ocular hypertension. The evolution of the hypertension was favorable, just with eye drops, and a 5% in the children we did perform a trabeculectomy. The evolution was favorable with a good final visual acuity, and 60% of our patients. About the complications, the most frequent one was the hypertension and the rebleeding, and hopefully just 6% of our patients had a hematocornea. When we compare our study to other ones, like the Kern study in UK and Hamani study in Tunisia, we can see the similarity about the frequent state of hyphema. It was the second one, like our study. Also, the surgical treatment was performed just in 10% in the Tunisian study, and the other one, the French study, in 6% is pretty similar to our study. So the hyphema, traumatic hyphema, is very common in children, where the diagnostic and therapeutic is an emergency. The visual prognosis depends on the stage of the hyphema and the associated lesions, where the importance of finding and treating associated damage. There are multiple treatments like tracks, strict rest, and the indication for surgical treatment should very well codified, as we know that the inflammation is very, very high in children. Under treatment, the evolution is generally favorable. Rebleeding, cornea, and ocular hypertension remain the serious complication. For the conclusion, traumatic hyphema is a frequent and serious condition in children which can affect the functional prognosis of the eye. When the diagnosis is made, management must be early as possible in order to avoid complication. And of course, the best treatment is prevention. Thank you for your attention.
Thank you, Sarah, for an excellent presentation
Thank you.
on a very, very important topic. Dr. Hudson has put a question on the chat. What would you do, Sarah, to prevent corneal staining from long-standing hyphema? Would you consider surgery after a week or so, or after a long time?
After a week or maximum 2 weeks. Because in children, we are just afraid about hematocornea, and also we are afraid about the complication of inflammation. So we perform the 10% that they had like a surgical wash. It was after a week or a week and a half maximum.
Can I make a point, Nati sir? No, if I am audible.
Yeah, sure.
Yes, go ahead.
Yeah. So there are two parameters in question here. Of course, I'm not the cornea expert here, but the amount, the volume of hyphema. If there is a gradation of the volume of hyphema, the blood staining, corneal staining is dependent on two factors majorly: the volume of the hyphema and the intraocular pressure. So when is the ideal time you would like to drain? Suppose there is a 3/4 the chamber, antechamber is filled and the pressure is high. So when would you like to drain?
Well, if we have
antechamber wash.
Yeah, sure. So if you can see here the pictures, like here you have the different stages of hyphema. Here we have the first one, like the third one, and here the second one. We don't have the fourth stage here. But if we have the fourth one, like the full anterior chamber full of hyphema with blood, and also the hypertension. So we treat the hypertension first, and after that we see after 3 or 4 days. And if the hyphema is still full on the interior chamber, we did like surgical surgical wash, but not in the first time, not like on the emergency. We didn't wash on the emergency, especially for children.
Any timeline you have, 4th day, or you wait for the clot to take place before you?
We wait for the blood to take place because we had an experience that we did it in the emergency and the child rebleed after.
The best thing is to monitor the intraocular pressure and see the absorption rate of the hyphema.
Sir,
the guidelines to prevent the corneal staining.
Sir, can I make some points? Sir, can I make some points here?
Sure.
Yes, Dr. Naik.
Yes, sir. Sir, actually, there was a book, The Trauma by Singleton. Also, we are following the guidelines. If there is a pressure of more than 50 millimeter mercury for 8 days, then you have to drain.
Exactly.
Or if there is a hyphema more than 3/4 for 8 days, you have to drain. If there is full hyphema or total 8-ball hyphema, we tell it total hyphema or 8-ball hyphema, you have to drain after 4 days. If there is if there is patient having sickle cell disease or sickle cell trait, even the pressure of more than 22 millimeter mercury, you have to drain because they are the RBC, they are the deformed RBC can block the trabecular mesa permanently. So we have to drain in that scenario, even in low hyphema and low pressure also. Otherwise, the pressure wise, I have told, and hyphema wise, I have told. Thank you.
Thank you.
Dr. Kavita, is Kavita there? I think she's the next speaker.
Yes,
Can you make some comments on Dr. Sarah?
Yeah, I agree with her, and I agree with the other panelists also. Typically, I would wait for a week. If it's not resolving within a week, then depending on the pressure and the staining, if that's happening, then I would probably make a decision to drain that hyphema.
The pressure is 50, you can't wait for 7 days. The pressure is 50, you can't wait for 7 days.
Yeah, for 50, I agree, you don't wait for 7 days. What I meant was typically if there's a hyphema which is not clearing and if the pressure is fine, you can wait for a week. It does clear up with steroids and cycloplegia.
My also other concern was while of early drainage, I am a proponent of early drainage. because I have to see the retina. Because I use a technique which I was almost going to, because I lost my screen at that time on the scleral tear repair. After repairing, then I put a chandelier light at the other end. After forming the globe, after suturing everything, I shoot a chandelier light. If the hyphema is there, I clear the hyphema instantly, because with the chandelier light and the biome, I have an access to examination of the retinal structures even at that early stage. And under chandelier illumination, I sometimes see and cryo under direct visualization the posterior extent of the scleral tear. I know we have to do vitrectomy later on, but that's the school of thought I follow.
I'm not a retina person, so I will refer it for vitrectomy for you.
May I say something?
Sure.
A lot of the decisions at present are based on clinical impressions, because unfortunately there are no randomized trials or no evidence-based number of days or number of pressure equations, because these trials are very difficult to do, unfortunately. All we have is clinical impressions or the recommendations made by different individuals based on case series, and we are learning from them, but they're not the same as randomized trials or really evidence-based decisions. So we keep learning as we go on and see more and more results in different series. So this is a useful contribution, Dr.
Exactly. Thank you so much.
Can I say something? The status of open globe and closed globe injury hyphema will be different. If there is hyphema along with the open globe injury and with closed injury, the strategies will be different.
Yes.
Yeah, sure.
And I think that's what Dr. Santosh showed, that he also injects an air bubble so that the blood clot is away from the cornea to protect the endothelium, make sure the pressure is within normal. It's correct. I think excellent, thought-provoking presentation, Sarah, because I think...
Thank you. Thank you for the invitation. Thank you so much.
Practice, but I think we have to refresh our knowledge. Thank you. Thank you,
Thank
Sarah.
you so much.
We invite Dr. Mukherjee, who's our president again, to introduce the next speaker.
Can I have that slide of Dr. Kavita Rao? I'd have to introduce Dr. Kavita Rao.
Lakshmi, can you show the screen?
Hi, Ashok.
Lakshmi, can you...
We're calling the phone, I think. Let's be engaged.
Yeah, she is doing. No, she was trying to talk to Dr. Dash because he's having problem in getting in. That's why I told her to call. She has put the screen.
Yeah. It's a privilege to introduce one of the young trauma specialists or cornea specialists, Dr. Kavita Rao. Dr. Kavita Rao is currently the director of the cornea and refractive and anterior segment services at Aditya Jyot Eye Hospital, Mumbai. Dr. Rao has done her long-term fellowship in cornea at Cullen Eye Institute, Baylor College of Medicine, Houston, USA, and distinguished L.V. Prasad Eye Institute, Hyderabad. She has trained in phacoemulsification and advanced cataract surgical procedures at the prestigious Sankara Netralaya, postgraduate training in ophthalmology from KEM Hospital, Mumbai, received the University Gold Medal for the best student in ophthalmology. She has several research papers published in peer-reviewed international journals. She has presented her work at international and national forum. Now I present Dr. Kavita Rao to you to present her slides.
Kavita?
Yes, sir. So thank you so much. I'm just presenting three cases. Typically, a cataract surgery, when there is a corneal tear, we'll wait if the anterior lens capsule is not ruptured Or if there's no additional retinal surgery planned, we probably wait for sutures to be removed before planning the cataract surgery. This is the first case is a 2-year-old child where the anterior capsule was ruptured, and obviously for reasons of preventing myopia, we planned the surgery early. Just share the slide. So this, as you can see, that the anterior capsule is already ruptured. It is difficult to get a rhexis. So after using trypan blue, I am trying to make a rhexis. I have got been able to raise the flap, and I'm then extending that using the capsulorhexis forceps. After the rhexis, or even if you're not able to get a complete rhexis, even if you can get some amount of it, that really will help you in placement of the lens later, because it's likely that the posterior capsule also may be ruptured. Now, always place a 3-piece IOL, because as I said, you don't know the status of the posterior capsule. This is easy to place it in the sulcus if it's a child, and make sure you're suturing the main wound. And also another pointer was that sometimes you may need to look and revisit the main wound, like this the corneal tear was sutured I think 3 days before the cataract surgery. You may need to go back and resuture that, so that you have a watertight chamber. Now, this was a patient that was doing a combined surgery with Dr. Natarajan. He's put in his ports earlier. So I'm putting in trypan blue, and here I'm able to get quite a decent capsulorhexis. The cataract is fairly soft, so I've just put an AC maintainer, and I'm removing the lenticular matter with just using the one single piece cannula. And there is anterior vitreous. So as you can see here, I'm doing anterior vitrectomy, and the reason to show this was that it's not necessary every time to do a lensectomy. Like a lot of retinal surgeons just do a primary lensectomy. You can, in our center, we do try and always place in an IOL, and try and see and retrieve if there is any capsular remnant here. As you can see, there is a lot of synechiae. So it may take some time to break the synechiae and release that. And of course, even in this case, it's always better to place a 3-piece IOL, because even though there is a rhexis, I think a 3-piece IOL, because there's no posterior capsule, a 3-piece IOL would be ideal in this situation. So once I've been able to get that synechiae to be released, I have placed the IOL. Just forward this maybe. Yeah, so the IOL placement here, again, if you feel that the posterior capsular tear is much larger, one tip I would give is that you can release the the leading haptic in the anterior chamber. Though in this case I didn't do that, but sometimes that helps. You can release the anterior the haptic over the iris, so that you don't have a condition where you're actually dipping the IOL into the vitreous. So after this, then once that is well in place, the main wound, I suture it, and then Dr. Natarajan takes over. Now, this case was actually a patient of mine. I had done her corneal graft, and all sutures are out, as you can see. She came with blunt trauma. Now, typically in this scenario, you would just ideally suture the graft, again let the the graft host junction heal, take out the sutures, and then do the cataract. But she was from the rural area, and also the cataract, as you can see, is mature. So in such a case, we go ahead with suturing the corneal graft. Suture it like you're doing your corneal graft suturing. Take radial sutures. Then you can address the cataract. Cataract, when you're doing cataract surgery, have used trypan blue here. Just a tip that do not you go through the graft host junction when you're doing the phaco. Make sure you're entering, outside of the graft host junction. You can get a rhexis here, even though it's a mature and intumescent cataract. I have managed to get a fairly small rhexis. So as I said, like the entry, as you can see, it's beyond the graft host junction. Go ahead with your cataract surgery. Or in this case, it's a good idea to have the soft shell technique where you're using both viscoelastics, because you're worried about the endothelium. Again, I have in most of these cases, I do sometimes prefer to use the 3-piece IOL, and make sure you're suturing that the graft host junction also, and your main wound in this case. So of course, the issue would be about IOL power calculation in this kind of a scenario, but oftentimes you may have to use the other eye for helping you. So thank you so much.
Excellent. Dr. Kavita, and I think my presentation also, I'm going to show some cases operated with you on cornea, PK, and vitrectomy. The Thanasis and Hudson, and we have Dr. Nicholas Charles from Argentina, and Dr. Hudson. Any comments?
Hi, good afternoon there. One question I want to do to the doctor. In the first case, you told it was a kid, a two-year-old kid. Do you perform anterior vitrectomy routinely? Do you do an anterior vitrectomy?
No, I did not. The posterior capsule was not intact, so I really did not need to in this case. Yes, but your point is very valid. If it's a child, one should be performing an anterior, you do a posterior capsulotomy because you don't want a PCO to form. In this case, it was actually already ruptured. So there was no need for that for me.
Okay.
Yeah, but Dr. Kavita, I think you could have done a vitreorexis because I saw that the anterior capsule was not very integral, so you're struggling to pull off a good rexis. So you could have done everything with the vitrector right from the beginning, the anterior capsular rexis, followed by the lens power aspiration, and then convert the pre-existing lens into a regular one on the posterior capsule as well, and then go ahead with the three-piece. I think it's an excellent idea. I think you get the message very clearly. To implant a three-piece, multi-piece IOL in such cases with an optic capture. If you're implanting it in a 2 years old, there has to be an optic capture behind whatever little remnant of anterior and posterior capsule you have, so that they do not come in contact with the iris. The eye is already traumatized, so you can expect a bit of anterior chamber reaction post-operatively. So it's a good idea to not expose the optic to the undersurface of the iris. Yeah, thank you. Great job.
The scenario can be quite variable in cases of which have had a previous corneal scar or corneal injury, open globe injury. And you have to actually take into cognizance the visibility, the status of the anterior capsule, status of the posterior capsule, status of the vitreous. And as Anurag said, anterior vitrectomy is a very good idea because visual excess opacification can still occur even if there has been a posterior capsular gap earlier. So when you are placing a lens after that or before that, you should possibly combine it with the vitrectomy. Visualization can be aided by staining in which cases where visualization may be affected because of the corneal scar.
Yeah, the other small point I wanted to make, Dr. Kavita, it's actually a question. In the post-PK cataract that you showed us, I thought the graft host junction was pretty peripheral. Did you enter limbally or did you make a sclerocorneal section for the phacoprobe to enter? Where did you place your incision?
Unmute, please.
If I've had a very large graft, then I would prefer to go and make a scleral tunnel and enter the limbus. This was just, I think, around a 7.75 mm graft. So I could get away with making a corneal entry, which was a little away from the graft host junction. But your point for discussion is very valid. If the graft size is larger, then it's a very good idea to make a scleral tunnel and enter at the limbus. In some of the patients where I have a therapeutic graft which have survived and are doing well, large therapeutic graft, and that's the plan which I follow. I actually excise the conjunctiva and make a scleral tunnel.
Thank you.
Thank you, Kavita, and thanks a lot. So I think the next speaker I have to introduce, and I hope you'll share, and I'll share the screen. So the next speaker is Dr. Hudson Nakamura, who is my very good friend. Dr. Hudson Nakamura is a medical specialist in ophthalmology and specialized in retinal vitreous. He did a fellowship in vitreoretinal disease in Toronto, Canada at the University of Toronto, and another retinal fellowship in his hometown city, Goiânia in Brazil. And he completed his study from the School of Medicine at the Federal University of Goiânia in Brazil, and residency from the base hospital of Federal District Brasilia, which is the capital of Brazil, and former attachment as a member of the American Academy of Ophthalmology, the Brazilian Council of Ophthalmology, Canadian Society of Ophthalmology, and also RO Association. And he's currently working as professor in the Department of Retinal and Vitreous, a course of medical residency in ophthalmology and fellowship in vitreoretinal diseases. And I think all of you know me as a something like a fountain of energy, but I think he's another man who I can't believe I can't match his energy. He's the founder of Retinal also, which is a group of retina people from, and I think he asked me to start, and we are having it on 1st August. I just realized while reading it, I want to tell Hudson and all the people here that at 1st August, we are having multiple programs, and I'm also a co-founder of Retinal. 1st August, we have a 30th anniversary, and there is another program from Dr. Fabio Nogueira from Brazil again. He is having some 52-year-old hospital, some celebration same day. And our hospital, we have 30th anniversary. We are celebrating with Singapore National Eye Center and St. Erik's Hospital, Karolinska in Sweden. And I think, anyhow, 1st August is going to be 4th Retina. Again, Dr. Hudson will be doing, and I'm also taking part. So off to you, Hudson. You can share the screen. I'm stopping the sharing. So what I want to tell the source of energy is he actually started a program a year back where he wanted me to comment on a video. He used to send in the morning and ask me in the evening, and I couldn't match his interest. And I did the first webinar with him on March 28 when everybody was perplexed what to do. I think me and Hudson just started the webinar, and I think nobody was doing that time. And I'm happy that we did it, and it was a midnight for me and morning for him. Anyhow, now it's a reverse, evening for me and morning for him. Thank you, Hudson.
Hi, good morning. I'm so happy that you are the founder, together with me and others, of the Retinal. It's an honor for me to be here, and I feel happy that OSOS also was born in 1969, the year I was born as well. So it's an honor for me, and I'll share my screen. As you can see, we already put our videos here in our Retinal channel, and I invite you, as Dr. Natarajan invited, for our Retinal meeting next Saturday morning. So I'll start with the vitrectomy for the macular, the dislocated lens. Can you see the screen? So honored to be here, and we have this dislocated traumatic cataract, and we used the perfluorocarbon liquid to remove it. And as you see here, it was moving around, and the patient was aphakic. And we started the vitrectomy, and I was listening to Dr. Nikolopoulos Anastasios talking about not grabbing the lens at the retina, otherwise you could damage the retina, and that happens. And this is an advice from my professor, Dr. Wachinlem, as well. So you have to actually pull it away with the cutter towards the mid-vitreous and make it float. And we like using the perfluorocarbon. Some cases we don't need to use the perfluorocarbon liquid, and we are attempting to remove the lens now with the cutter. But the lens is quite hard, so our attempt was not successful, even though from our last Retinal, Dr. Oshima showed a case using 10,000 cuts. He called this a sandwich technique. He used the cutter to remove the lens, but now we had to use the fragmentum, and that came towards the port easily, because, you know, if you control the settings, it comes very cool, and you have to fill the eye and not use too much power, not too much vacuum. And interestingly, you removed now the all the lens, but you see you have the macular lens. You see some PFC droplets. I think that's what Anastasia was talking about. We are afraid of leaving perfluorocarbon liquid there, and so you got to use this macular lens to look for any droplet and vitreous adhesions around the macular surface or in the mid-periphery. Otherwise, perfluorocarbon could be damaging in the long term. So we are doing here with the very good visualization, and because the lens was floating around the eye, we did this endolaser at 360 degrees to sort of protect just one row, protect the retina peripherally, because we didn't know whether, even though we did retina surge beforehand, but now we are putting a line to block any possibility of a break or a imaging. We have the wide angle systems, and then we end the case with the air fluid exchange. And you see the whole periphery. The retina is totally attached. A very good outcome patient, and this patient was referred later on for the anterior segment surgeon to choose the right intraocular lens for him, and that was fine. Good case, and yeah, this is one of our cases. If you want me to proceed with the other case, I can do that now. But if you want to discuss it right away, there is no problem for me. And
you can finish, Hassan. You can finish your case, and then we can discuss together.
Okay. So let me stop sharing. Yeah, that was a cool case, and I liked your lecture, Anastasios, about using or not a perfluorocarbon liquid, and not getting the lens right at the retina. You have to make it float, and that was interesting. And you gotta remove all cortical adhesions and make it float. And I don't always use perfluorocarbon liquid unless I have to. In this case, the lens was quite heavy and dense, so I had to remove it and put it, in the safe area and do a vitrectomy.
And any Dr. Alok Sen or Thanasis, you want to say something? You have to unmute, Thanasis. Yes.
No, I'm unmute. It's a beautiful presentation with a very nice video and a very wide view and very detailed, and you love the result, because after all is to do the same thing together to make a result that doesn't have the retina. But about PFCL, about perfluorocarbon, another issue is that if you do my technique, and that means breaking the lens into small pieces inside the eye, they tend to go down and hit the retina. If you put perfluorocarbon in order to protect the retina from these droplets or from the lens, you have to remember that perfluorocarbon can stay in the eye as long as you don't do vitrectomy, as you don't disturb the eye. If you start doing vitrectomy and you got an infusion line working, then perfluorocarbon is going turbulent. That means perfluorocarbon can go above the fragments, above issues that we have. And then you do exactly what you want to avoid. They're pressing against the fragments on the retina. Perfluorocarbon is a heavy liquid, it's pressing against the retina. So we got damages from pieces that they were covered by perfluorocarbon, because perfluorocarbon cannot stay behind if you have switch on the infusion line. It's turbulent. And the second issue is that you can remove. Of course, if you use perfluoroctane and you leave a little bit inside, it doesn't matter. It's going to dissolve. It doesn't do any damage. That's the main idea. And the second idea why I'm avoiding the fragmentation issue is that the focal fragmentation for the hands of somebody who doesn't know exactly how to do it, that means you have to open, it's usually 19 gauge. And you use sometimes 25 to 23 gauge infusion line. So you get infusion going inside the eye less than suction that you're doing with a, and certainly when you're in the lens and you go through the lens automatically, then you try to have BSS in the eye, and they suck so quickly, the BSS, and you got choroidals coming to your face. So that difference between infusion and suction that you got. So you have to keep the lens as you very well showed in the middle with your infusion, with your suction, and you don't have to go, but some of my fellows go through it because they're happy that you chew it, you go through it, and as soon as you go through it, you find yourself in the BSS, and infusion line is not enough. That's why the tissue, you can go to the infusion to the 60 millimeters when you do a fragmatome situation, in order to have enough fluid to compensate for the 19 gauge of fragmatome. And that's the main issue. It's not so much everything. That's why I said that you have to learn how to chew the lens inside and use the right can. But the results are beautiful, and I really liked your video and your technique. Thank you very much.
Yeah, thank you very much.
Can I ask a question to Dr.
Sure.
Yes.
So,
yes, you can ask the question.
Yeah, my question is to Dr. Athanasius regarding that. At that time, I just lost my audio, and in India, we have seen that we encounter a lot of hard nucleus, and I have a technique of using a spatula and the phacofragmatome to divide and conquer, so to speak. But I always prefer to use the phacofragmatome. I understand your concerns regarding the ultrasonic energy and its effects on the retina. But just with a cutter alone, and I could see your settings, it was around, when you were operating, it was around 4,000 cuts per minute, and the suction was around 450 or 550, if I remember correctly, the settings. Do you think we can remove the hard nuclei just with a cutter alone?
There is a limit.
Yes.
There is a limit. I'm sure there is a limit. There are cases that you cannot do my technique. And in this limit, you have to know how to use the fragmatome. So there must be another session of how correctly to use the inside fragmatome. It's not the same like you do a fake one with the eye. But when you have such a hard thing, you have to remember that I'm pointing in my PowerPoint that I'm using 200 cuts per minute when I'm cutting, not 4,000. 4,000 was for the vitrectomy, especially. 2,000 cuts per minute, and I can get it a little bit more when I have small chops to do that. Also, I'm using a technique that I didn't show you. It's called eating, compulsive eating. I mean, I push with one hand the tip in the side, the cutter, in order to hold it there and not to go away, in order to chew it. It's for feeding, we call that. And in this way, you can do 80% of cases. You use two hands. That's bimanual. You need a illumination outside. Do you use the illumination outside? Do you use chandelier light?
Yes, in all cases.
So my idea is to do it manually, not do it one hand. Okay?
We do the same thing. But the only difference is that we use the
Rahul, can you share my screen?
Dr. Mehul, what were you saying? Mehul?
Yeah, Rahul, can you share my screen?
Dev Jyoti, or what is the name, sir?
No, Mehul, what are you doing?
Yeah, actually, I wanted to introduce Jayanta, next speaker.
No, next speaker is actually Dr. Sabyasachi has to introduce. I missed one thing. So before Mehul, we have to introduce Dr. Devjyoti Tripathi, which I missed. So Dr. Sabyasachi will introduce Dr. Devjyoti. So thank you, Hudson. We'll be again. We will have you again. You have one more presentation. Mehul, you will be doing it next, Dr. Jayanta.
Right.
So I missed it. I skipped one and went to the next. So Dr. Sabyasachi, you introduce Dr. Devjyoti Tripathi. Dr. Patnaik?
Sabyasachi, where are you?
We can see your screen.
Yes, sir. So it's my pleasure to introduce Dr. Devjyoti Tripathi. So he's an excellent surgeon and he is working as a faculty at L.V. Prasad Eye Institute, Bhubaneswar. And he's a fantastic teacher also. With this brief introduction, I present to you Dr. Debajyoti Tripathi to start his presentation and share his screen.
Am I audible?
Yes, yes.
Yeah, thank you, Dr. Sabyasachi. I realized that I didn't put enough details of myself up on that slide. But anyhow, thank you for the introduction. And I would also like to thank Dr. Nageshwar Rao, a dear senior and a close friend-like person to me, and Professor Subudhi, as well as Dr. Natarajan for giving me this opportunity. And good afternoon to people in Greece and Morocco. Good morning to people in Argentina and Colombia, and an early good evening to everybody in India. So can I start sharing my screen, please?
Yes, yes.
Thank you. So my talk for today is based on canalicular repair. And what I'm going to show here is something that is a little bit in the past. This is not something that we routinely do now, but this technique has served me very well as a backup technique in places where there might be lack of resources. And that's why I termed this as something that's a lost art. Here we go. So canalicular trauma is reported to be about 16% in all eyelid injuries, and it sometimes can be so subtle that it's not recognized till it heals like this by secondary intention, and then causes lifelong epiphora, which can be quite debilitating for the patient. The obvious ones are easy to recognize, but it's the subtle ones which are the ones which end up creating the long-term issues. These days, this is what we would actually do with the canalicular trauma. This is the monocanalicular stent, which is the stent which is used most often today in repair of canalicular injuries. And you can use two of them. But this is the instrument that I was talking about. A slight regression into the past, if you may. So this is the pigtail probe. When I was a postgraduate student, I used to see my teachers use this probe to repair canalicular injuries. But then as I became a fellow and as I became an independent practitioner, this instrument vanished from practice as newer techniques and newer props like the stents came into being, and they were definitely much better. But let us see how this instrument helps you sometimes. So this was a 7-year-old child with a 5-day-old canalicular injury, not certainly the ideal way or the ideal condition that one would want to repair a canalicular injury in. But then we do get a lot of cases which are not the most ideal. In this, we were lucky to identify the medial cut end of the canaliculus very clearly. As you can see, the mucosa there. And we started the canalicular repair in the routine way. We used a mini Monoca canalicular stent, which was fixed to the punctum there with the collarette being inserted. And then we started cannulating the other end of the canaliculus through the medial cut end. And then we ran into a bit of rough weather. And there you can see me attempting to cannulate but I was unable to do it in spite of all my efforts. And then we thought of using the pigtail probe. So this is the actual step in the pigtail probe which requires the skill. The probe comes out from the other cut end. You thread a 6-0 Prolene suture, and then you retrieve it back as you pull back the pigtail probe. And this suture that comes out through the upper punctum is the guide wire. Now this we are using
a tube which we often use as a stent during our lacrimal surgeries, and the 6-0 proline suture is threaded through the tube, and that is what acts as the guide wire, and it's pulled out. It's pulled into the medial cut end of the lower canaliculus first and out through the upper canaliculus. So once it exits, you have the tube in place and the threaded suture as the guide wire, which lies within the bore of the tube. You place the sutures, repairing the small lid laceration that is accompanying the canalicular tear. And then this is another step in which you have to be careful that you trim the tube, but you do not actually snip the guide wire in between, because that's what is going to hold the tubes together. And then when you tie the knot, you actually form what is an annular stent. Then you rotate it so that the knot is not exteriorized, and then you complete the pericanalicular sutures. And that's how the surgery is concluded. And when done properly, it actually gives excellent results. So as I said at the beginning, I really don't advocate this as the primary way of repairing canalicular injuries. This is definitely a very, very helpful technique if you have the skill to do it, and you can use it as a backup technique whenever the need arises. Thank you.
OP Agarwal is there, or anybody? Mehul, you want to make any comments? I think excellent, sir, to show again, because as a retinal surgeon, when we are going narrower and narrower, we only see only the retina and vitreous and nothing else. And that's why I remember my mentors, like particularly Dr. Badrinath, used to say, you should see the patient as a whole, then eye as a whole, then orbit as a whole. So I think every presentation here, including the canalicular tear, what you showed in the morning, Dr. OP Agarwal showed. Dr. Mukherjee and Dr. Mehul, any comments?
Rahul, can you share my screen there?
Yeah. But in the meantime, Dr. Mukherjee is making a comment. He'll share.
The surgery has been done excellently, and pigtail guide, actually I have seen operated by our teachers who have not ophthalmoplastic surgeons. So they help a lot, particularly in cases of little older case, not a fresh case. So pigtail instrument is useful in those conditions. That is what I have seen. I don't have my personal experience.
I think this is a phenomenal day, because what is not uncommon is the failure to cannulate the medial end. Though you identify the opening pretty well, at times you actually fail to cannulate. And I have experienced it many times, but I don't have any experience. And I thought the pigtail technique is actually having a very steep learning curve. I tried it and it failed. But the kind of documentation that you have and the thing that you showcased just now is exceptional. I think the way you threaded it and the way you sutured it to form a loop there and turned it inside was actually phenomenal. Very, very impressive indeed. Congratulations, Dave.
Thank you.
That's what I commented in the morning also. No, it has a steep learning curve.
I agree. The pigtail. Yeah, go on.
No, I said it does. It does have a very steep learning curve.
Yeah, I agree. I agree. It does have a steep learning curve, but in this particular case, you could see that we were able to identify the medial cut end very well. Once you identify the medial cut end very well, the cannulation becomes easy. But in those cases where you have an injury where the medial part of the eyelid is almost avulsed from the medial canthus, what happens to the remaining canaliculus is that it retracts inside and you can't see the mucosa very easily. Remember, the closer the laceration is to the medial canthus, the more difficult it becomes to repair the canaliculus. So once you are not able to see the mucosa, that's where the pigtail probe really helps you if you know the skill. Because you can actually bring it out through the cut end of the mucosa even when you are not able to see it properly. And that is where the pigtail probe is a big advantage over all the other techniques that we have now. But then it's true that you need to practice a lot with it to get that right.
No, even if you identify the opening there, at times what I found is, particularly if, as you mentioned, if the laceration is very close to the medial canthus, then the medial part of the cut end actually turns in. I mean, if you are able to identify the opening also, it becomes a little difficult to cannulate, particularly in the pediatric age, who turns in, and the apposition, I mean, one part of the cut end is turned out, the other is turned in. I mean, it could be easy for you guys, for the plastic surgeons. For us, it becomes difficult. Even if you identify, I'm saying, even if you identify the opening, it might be a little difficult for you to cannulate. So, there also it can come in very handy, this technique, but provided you're able to do it as you suggested.
Agreed. Yeah.
Thank you, Dr. Tripathi. And I think even though you said it's an old technique, but I think you revisited it. Maybe you should publish it. So now I request Dr. Mehul Shah to introduce the next speaker.
Thank you very much, sir. It is my privilege to introduce Jayanto Sekhar Guha, who is a senior vitreoretinal surgeon in Delhi, practicing since 2 decades. And he is chief operating surgeon in Sai Retina Foundation. He is also retina in charge in many other, like in Ghaziabad or Lions Hospital in Srinagar. He is a visiting retina surgeon to Uzbekistan, and he is recipient of many awards. He is the first to have a MIVS and first VR surgeon to use the wide-angle system like 1, 3, and 3. He received several awards from Opthalmic Society. So he has done thousands of vitreoretinal surgery over past years, various centers across North India. He is proficient advanced VR surgeon like macular rotation surgery, autologous RP, patch graft, optic nerve management, and massive submacular hemorrhage and IURBs. So we invite Dr. Guha to speak on this only subject.
Yes, sir.
Guha, you can share your screen, I think, or Guha?
Thank you very much, Dr. Mehul, for the kind introduction. Am I audible?
Yes.
Internet connection problem. Am I audible?
Yes.
Yeah. Am I audible?
Yes.
So, thanks for the kind introduction. And
sir, may I share your screen, sir, from my side? Dr. Jayan, sir, may I share your screen?
Yeah, please go ahead, Rahul. Please go ahead. So I'll be demonstrating a few bimanual techniques which are quite innovative to tackle the intraocular foreign bodies, and I will end up with the pellets. Sometimes the foreign bodies, like this case, for example, the wire is located very near the aura. So, and all this is under bimanual. And important things in this foreign body is that you have to reorient the foreign body so that the long axis, I'm using a magnet and the forceps in both the hands. One hand with the magnet, and then orienting the foreign body with this long axis along the A, I take it out. And this is an embedded foreign body, embedded very near the fovea, as you can see. So I'm again using a bimanual technique with the MVR blade in one hand, and sorry for the reflexes, and the forceps in the other. And here is an old foreign body. You have to incise the capsule around it, and then you free it, and then again using a magnet in one hand and the forceps in other hand, you take it out bimanually. And also along with it, I could take out the subretinal fibrosis in this case. And here is another case of near the aura, there was this copper wire Again, using a Bimanual technique, you use the forceps and the magnet, the two forceps, in fact, in this case, and take the foreign body out. And this is a case of a pellet. Just can you pause, Rahul, for a second here? Yeah, please pause. So from 2010, I have been removing pellets, and in the first few cases, as in fact, these are all recordings of 2010. And I didn't have an instrument to take this foreign body out. So my assistant suddenly told me that very innovative idea, use a Calesian scoop. As you can see, I could effectively place the foreign body. At that time, the pellets in Kashmir Kashmir were round, shaped, and around on the Calesian scoop, and I could take it out. And then, of course, now we are using the. Please continue the video, Rahul. Now we are using the Papas forceps for effective removal. See, I have removed this foreign body pellet, and here it was embedded in the vitreous hemorrhage, the pellet, and suddenly it appears and it falls down. Then again I use the scoop to remove this pellet. And of course, another case where the pellet with detachment, I'm removing this with another innovative instrument. Now, here, of course, I will show it at the last. Papaya's forceps. Here, this can remove any foreign, including pellets. It's a wonderful instrument. But only is there one disadvantage. Just pause the video now, Rahul, again. Yeah, so one only disadvantage of using the Papaya's forceps is that I have also told him to work on this aspect, that it opens up suddenly to 9 millimeter, because it can open up to almost 9 millimeter jaws, almost like a hippopotamus opening its mouth. So I've asked him to make the opening a little more gradual process by some spring mechanism, some dampening mechanism, so that it opens gradually. Now, the next part of the presentation is the ILM peeling in traumatic macular holes. Please commence the video, Rahul. Here we can see it's an old video, so I'm peeling the ILM without the aid of PFCL, but you can still effectively do after staining. I used to do at that time. Now, of course, I'm peeling mostly under PFCL, but I used to do a fluid exchange from the peripheral tear and settle the retina, stain it, and then remove the ILM. So this is the conventional ILM peeling that I am demonstrating in the early days. Now, in the next part, you will see this is the flap method when I am using the inverted flap, which is the preferred technique these days of ILM peel. And at the end, I use a PFCL to tuck the. And here is a case. Just pause the video. Now, here is a huge macular hole. It's a case which was operated elsewhere first. It's a case of traumatic detachment. With macular hole came to us with severe changes. With a huge macular hole. So we had to do a retinal amount of ILM will have plugged the hole from epidemic subretinal space, as you could see. Techniques. Now, please commence the video. Yeah. So the PBR, the first was to demonstrate the fact that ILM can't plug this huge macular defect, macular hole. These are subretinal membranes being removed bimanually. and then after in injection of PFCL from the supratemporal part, we mark out transplant with the PFCL, we drag it onto the macula and end the surgery with the PFCL siliconics. Thank you so much. That's all, sir. Thanks for the opportunity.
Guha for showing wonderful technique. And I think Dr. Hudson, can you make some comments? Mehul, you have to mute your patient. Mehul, you have to mute.
Yeah, sure.
Hudson, you can comment.
Yeah, I comment that it's very tough, difficult to remove any membranes on the retinal surface without, having the retina stable. And this is a really cool case. You could have done that without the PFO, and you remove the thing, and it's very tough to do. I like using the PFC for many things, especially for these. And after doing this air fluid exchange and the brilliant blue, I see very good the ILM. And in case I don't need to see the ILM, I want to see the epiretinal membrane by contrast, I remove the membranes. But really, really tough and really beautiful case to watch.
Hugo is from Colombia. He's another excellent trauma surgeon from Colombia. Hugo, can you hear? Yeah. Can you come? Yes, hi Hugo. Good morning.
Hi, how are you?
Very good.
Good morning and good evening in India. How are you, everybody?
Wonderful, wonderful.
Yeah, it's a beautiful case. I agree with Hudson. And it's very difficult sometimes to take out these intraocular foreign bodies. So I think the technique in the patient, in the delicate with you take out the foreign body is the success in many cases. Perfluorocarbon is a very good instrument. It's the third hand that we hand in these cases.
Hello, may I make a comment?
Please, sir.
It was a great presentation and very current in everything that is happening around the world now. The only thing that I think it's my key point on that is that he's using the handshake technique to take out the body. And because you know that I hate to open up a lot the sclera, bimanual handshake technique in order to take out the foreign body with the smallest diameter from the eye, it's one of the very safe ways to do it. And if you use a magnet with one hand, then you hold it with a forceps with the other hand, and then you put another forceps in your other hand, and then with those two forceps, you can guide this outside the eye. I think if that was the only presentation that you did, it would be worthy to be seen by thousands of people and take home message. That's what I wanted to stress. Thank you very much for showing that.
Thank you, Thanasis, and thank you, Guha. Wonderful to have you with us and to showcase. And I think next is Dr. Alok Sen, another veterinary surgeon.
I hope you don't mind. It's noon in Greece. Okay.
Enjoy.
And this is what I call OSOS. So if I start singing in the middle of the lunch, you know that it's coming to my head.
Yes, no problem. So, and I'd like to introduce Dr. Alok Sen. He's a senior consultant, Department of Retina and UVA Sadguru Netra Chikitsalaya Chitrakoot. He has got 15 years of experience in vitreoretinal surgery teaching and training, 33 publications in Index Journal. I'm happy to say that thanks to Dr. Alok Sen and Dr. Jain for having me as a visiting faculty. We are trying to do research together. And I wanted to say, Thanasis, they are doing the maximum number of cataract surgery in the world in one center. And they are doing 120,000 cataracts in a year. And the number of vitreoretinal surgery also is quite high. They have 26 modular. Yes.
May I send you my dinners there, because he's working in Paris, and in a hospital. And when they say they do 10 cataracts per day, they're celebrating. So can I set Constantinos to see how real life
Yes,
is? Okay?
Constantinos is his son, and definitely you can
My
take
son, yeah. He's working with the Rothschild Institute in Paris now. He's a vitreoretinal surgeon, and he would always love to come and see how coronavirus is doing in India.
Okay. Only thing the flights have to come. Yeah.
It would be a pleasure to have him.
For 100,000 cases, he will come walking.
Yes, I know. And Thanasis, I'm planning to do create a Guinness record with Dr. Alok Sen, operating in all the 26 operation theaters he has. I want to do one after another in a day.
I'm really proud. I'm really proud that I have seen you operating in one operating theater, only one, and eating at the corridor because there were no dining space. We were sitting around in the corridor, and then the table come from the ceiling.
Yes,
I remember that, and we had some lunch together. But these were the beautiful days of seeing you doing vitrectomies like nobody else has done before. And that was just 5 years ago, 4 years ago. I don't remember it.
25 years ago.
25. Oh my God. 25 years ago, you had a center, you had a hospital, and you were doing excellent vitrectomies. 25 years ago.
Yes.
And you still look the same. This is that's why I'm asking what kind of medicine you take.
Chilies.
You still
Chilies, sir. Chilies. 3 times a day.
I know.
So I'll stop sharing my screen, and oh, sorry, Lakshmi has to stop sharing. Lakshmi, at Alok, we want you. Alok is one of the bright stars of India, vitreoretinal surgeon, and I'm happy to say, like, all of us had an opportunity of having fellowship, but I think I admire him. I learned from him, and he allowed me to operate a giant tear in a one-eyed patient in Chitrakoot. Yes, Alok.
Yes, sir.
Alok?
Yes, sir. I'm just sharing my presentation. So thank you so much for this opportunity to the Orissa State Society, and especially thank you to Professor Natarajan. He has been always very kind to me in every forum. Thank you for the kind introduction. We have all been seeing him operating for so many years at different life surgical workshops, and we have learned a lot from him. After a very excellent, I would say, an excellent presentation by Dr. Jayan Kua, who is a senior friend of mine, I am just presenting a very short, you would find it very a trivial video of intraocular foreign body, but the concept is that we have started doing stage procedures in the traumatic endophthalmitis with intraocular foreign body. So we all know that an intraocular foreign body is an emergency, and you have to remove it as quickly as possible so as to prevent an endophthalmitis. But what is not clear is when these patients present with an endophthalmitis, what do you do then? Whether you do it in the same setting or you do it as a stage procedure. I'll just share one of my cases. And so is my presentation there on the screen? Sir?
Yes, we are seeing Alok.
Yeah. So this 19-year-old male who presented to us after a corneal tear and cataract extraction done elsewhere, and he presented to us after 7 days of the first surgery with a PLPR vision. And you can see the clinical picture on the left side of your screen. He has a repaired corneal tear with an hypopyon and dense fibrinous exudates. There is no glow. And the B scan shows an intraocular foreign body with dense vitreous exudation. So what we decided was to do a pars plana vitrectomy with intravitreal antibiotic as the first stage of the surgery. And as you can see, this is after 2 weeks of vitrectomy. So we had advised the patient to review after 7 days, but unfortunately, as it happens in India, most of the patients, they come at their own wish. So he came back after 2 weeks, and what you see is that the endophthalmitis has almost completely resolved, and there is no hyphema, hypopion. You can see the sutured scleral wounds, and the fundus picture shows some vitreous membrane, and there is a vitreous incarceration at the posterior pole, and then a membrane which is extending towards the disc from that area. And the B scan shows the intraocular foreign body still there. There is a localized retinal detachment, while the rest of the vitreous cavity appears to be clear. So I'll show you the video right now, and you can see what you can see here is that there is an extensive membrane which is all across the pars plana, extending anteriorly behind the iris. So what we decided to, since the infusion cannula was not visible, we decided to use an ACM, and then we did, with the use of the cutter, we removed the membrane in front of the cannula. So and you can see that cannula now been exposed in the vitreous cavity, and once it was in the vitreous cavity, we completed the PVD, and once it was done, as you can see, the foreign body was quite anterior, and this has been our experience that most of these foreign bodies are very anterior, where we are unable to visualize them during the first surgery. And so we tried to remove using a 23 gauge forceps. As it was large enough, it was not possible to hold it with a 23 gauge forceps. So we used the tooth forceps to grasp it. And with some difficulty, we were able to grasp it, bring it into the anterior chamber, reorient it to the long axis, and remove. So before this, we had injected viscoelastics. And after this, we did remove the posterior cortical vitreous and the membranes. We tried to remove as much of membrane as possible. We left this incarcerated membrane, just trimmed it off and left it as it is. And you can see that that was a membrane over the disc as well. So we used the forceps to remove it as much as possible, and then just trimmed it off. This was followed, and as I said, that there was an extensive membrane overlying the pars plana and the ciliary process. So we tried to remove as much as possible so that there is no membrane lying over the ciliary processes. And since we could not remove it completely, we filled it with oil, considering that this eye may go into hypotony because of lack of ciliary perfusion. I now stop my presentation and leave it for discussion. Thank you.
Thank you, Alok, and excellent. I think it is not a trivial video; it's a very important video. So, Dr. Thanasis and Hudson, anything you want to ask or comment? But Alok is a great surgeon, and I think he's working in a most remote part of India where there's no flights, and if you go from Lucknow, it takes 6 to 8 hours, and if you go from Allahabad, about 3.5 hours by road. So it's a long journey even to reach his place, and there's nothing around, and it's like a forest, and they made a hospital there.
If they tell me that if they tell me that this surgery was done in the Mayo Clinic in the States, I would accept it. It's so perfect to every aspect, to every detail. The view is so beautiful, and the whole video is so updated that I think it's 10-fold times better when you do these things in an isolated area, and I really appreciate that. I don't like to comment on any details further to that, but I would like to tell to everybody that a retina after endophthalmitis and foreign body embedded, it's very fragile. And all the technique of not scratching and not peeling and not making any tears or any hemorrhages after that, it's excellent. The only thing I wanted to say is congratulate you. That's all.
So can I ask a question, Nati sir?
Yes, yes.
So yes, sir.
Yes.
Yeah. So Alok,
Yes, sir.
wonderful presentation. Wonderful.
Thank you.
And as Dr. Athanasios says, I encore whatever he says. And we can all see that he's enjoying his lunch. So how many days after the primary cataracts, the primary repair, did the case come to you? Can you just recollect for us?
2 weeks. 2 weeks.
2 weeks. And
the primary repair 1 week. 1 week after the primary repair. After the corneal tear repair, the patient presented to us after 1 week.
Okay. And then you did this surgery after 1 week. This was the
So we did primary vitrectomy. Yes.
Dr. Alok,
Yes.
You showed that in the first slide you showed that there was a foreign body you have already identified on B scan before going for the first surgery. Am I right?
Yes, yes.
Then why you could not locate the foreign body?
Sometimes, yeah, very good question, sir. Sometimes in these young patients with very dense or very gel vitreous, the vitreous exudates are so thick that at times, and especially what we have noticed is sometimes these very anterior, as in this case also, very anterior foreign bodies are very difficult to locate with the dense vitreous exudates and all. So what we have realized that if we do a stage procedure, control the endophthalmitis and inflammation initially, and then proceed and do foreign body, it helps. So that's the reason why we didn't go in aggressively locating the foreign body and trying to remove it in the first go, and did it as a second stage once the inflammation and the infection was under control.
So this is intentional, but the patient did not come in time. Okay.
No, it was intention, and we did it as a stage.
Thank you, Alok, for wonderful, stimulating video. And next, I request Dr. Das, the president of Orissa State Ophthalmic Society. Sir, you are celebrating 51 years of your state society, to introduce Dr. Nageshwar Rao. And I also wanted to do some change in the order. So next I will, after Dr. Nageshwar Rao, mine and Hudson will go last, because Hudson has already presented and I also had a presentation in the morning. So we will have Dr. Nageshwar Rao, followed by Dr. Nicholas Charles and Dr. Hugo, then Hudson, and then me last. Okay, Dr. Dash?
Okay.
Dr. Das, can you hear us?
Sir, Dr. Das sir is on desktop, sir. So there are audio output, but audio input is not there.
Oh, okay. So can I ask Dr. Sabyasachi to introduce Dr. Nageshwara? Sabyasachi or Dr. Subudhi?
Yes, I can introduce. It's my pleasure to introduce Dr. G. Nageshwar Rao, because we have worked together for quite some time. And he has done his post-graduation from RP Center, Delhi, and did his retina fellowship from Arvind Eye Hospital, Madurai. And after that, he was working with Rotary Eye Hospital, and then subsequently as associate professor, also continuing as associate professor at KIMS Medical College, Bhubaneswar, and has also his own exclusive retina center, the Vision Care Retina Center for Retina at Bhubaneswar. He has 12 peer-reviewed publications, 12 publications in peer-reviewed journals, and it's my pleasure to introduce to all of you. And I invite him to share his screen for his presentation. Dr. Rao.
So Dr. Rao did an exclusive trauma meeting last year in Orissa, and I was part of that. So Dr. Nageshwar Rao.
And today's program is also his brainchild.
Yes, yes, that's right. And Sabyasachi, if you don't mind, can you call Dr. Dash? And apologies, I think some technical problem he has.
Yes, there's some, I will sort it out, sir.
Right. You can call him and tell him. And Dr. Rao, you can come. And we'll ask Dr. Nicholas Charles next after that.
Is it visible? My screen?
No, you have to share the screen. No.
Sir, may I share from my side?
Why it has happened like?
Mageshwara, can you ask Rahul to share the video?
Yes.
Okay.
Yes, Rahul.
Are you sharing?
It has come.
Now your screen has come.
Your screen is there now.
Is it visible?
Yes, yes. Go ahead. You can play.
So thank you, sir, for kind introduction. I would say actually all credit goes to Professor Natarajan sir. Actually, with his guidance only, we could make this wonderful interventional potpourri on macular trauma. All my this one, respects to him, and we wish he will continue with us for years together, so that we can grow. And he's a well-wisher of everyone. So let me start I will be speaking two cases. One case, actually, this is the repetition of what we have seen earlier. So this is a 23-year-old male had left eye injury with bull's horn or cow's horn, and the visual acuity was PL with accurate PR. And in fact, this type of injuries we often see at our this one practice. So because most of the people are agriculture based and laborers, actually they get injured with bull's horn or the cow's horn. And the globe ruptures, in fact, today we saw so many cases of globe ruptures. Usually this one etiology remains like that only, cow's horn or bull's horn. So the first instance of when you'll see, actually at the local hospital, he was refused, and he was told that the eye should be removed. And he came, and I repaired this wound. Dr. Santosh was showing in the mob this one afternoon, because ends are very important is to identify the ends. Once you identify the ends, then the suture will, the integrity of the wound will be better. The second is, usually I take continuous suturing rather than putting interrupted. I don't know how actually it differs, but to me it behaves well. Actually, continuous suturing gives a better position. And I removed although the AC should not be disturbed, but I removed the clots from the AC. So much clots were there, and injected the air into the vitreous cavity and left. After 10 days, the patient has come, and this was the picture with ultrasound. And lucky that there was no much disturbance in the retina, only the vitreous blood were there. There was you can see the dialysis, iris dialysis here. A lot of thicky clots were there in the vitreous cavity. Removed. And then the iris, actually, the dialysis was repaired after taking out the blood and the lens. And the debris which was there in the retina, was actually, ultimately, he achieved 6/6 after SFIO after 3 months. So usually what I wanted to tell is, actually, this type of injuries usually often we see, but we should not lose our hope. We should keep our hope, actually, to repair this. Am I audible?
Yes. Carry on.
So we should keep our hope to repair these wounds and see, because you cannot expect the vision. Depends upon how severely the posterior segment is involved. Otherwise, you should, at the first instance only, you should not tell that this eye is gone, it should be removed. Not like, and the incidence of sympathetic ophthalmology also came down very, very less. So that is the reason, ideally, the hopeless eyes also should be repaired first and hope for the best. Thank you very much.
Thank you, Nageshwar Rao. I think you are doing
Another video I have.
okay.
So how to go? This is again a this is another video. 26-year-old male exposed to a dynamite blast while he was actually fishing in the river, and so many glass pieces have actually entered into the eye, and you can see the corneal. The cornea was fully studded with so many glass pieces, and he had even associated with this one fracture femur. He was there, and inside the eye, apart from the glass foreign bodies, there was a bit of vitreous hemorrhage. So I decided to remove. There was a tiny foreign bodies, were multiple foreign bodies there in the vitreous cavity with a large foreign body which was stuck into the retina, and I tried to remove. Here, after removing the gel vitreous and the vitreous hemorrhage, you can see so many small tiny foreign bodies were there in the vitreous which has been removed, and there is a large glass turbine sticking to the retinal surface. It was dislodged from there, and it comes to the macula foveal center. So one should put at that time PFCL, not to, because during manipulation sometimes it may rag the cut the macula. So PFCL is very important to push the foreign body away. Once it has been pushed, grasp with the forceps and remove. And finally, the retinal tear was repaired with the retinal tear was repaired with laser. And I left the eye with SF6 gas number, because once ultimately the vision also came very good, 6/6 at end of it.
Wonderful result, Dr. Nageshwar Rao. Thank you
you.
for getting 2020 is great. And Dr. Hugo, like to comment on him? Dr. Hugo?
Hi, hello. No, I don't
Yes.
have comments. Is this before comment? All techniques in ocular trauma is so difficult, but the patient and the is planificate the surgery before that is very important.
Thank you. So thank you. So thank you, Dr. Nageshwar Rao. Now I will next I'll share my screen and introduce Dr. Nicholas Charles. Dr. Nicholas Charles is from Argentina. He's a MD, PhD, co-director, Centro Oftalmológico Charles, Buenos Aires, Argentina, former Ocal Sociedad Argentina de Oftalmológica, chief in refractive, cataract, and cornea surgery service at COCH, and member of APTO, the Association Pan America de Trauma Ocular, the Pan American Trauma Ophthalmic Society, and member of AAO, ASCARS, SARVY, SAO, and CAO. And I've stopped my screen, Dr. Nicholas. And Rahul, can you share Dr. Nicholas?
I can share my.
Oh, yeah, okay, you can share. Thank you, Dr. Nicholas, for joining us from the Pan American Trauma Society.
Thank you, Dr. Natajan, to invite me, and thank you, the OSOS, for this wonderful meeting. I want to share with you this case. This is a movie, so we have to wait this. It is a case, as you see here, is a 4-year male that suffered from a penetrating trauma with screwdriver. He presented with an 8mm paralimbar scleral laceration with vitreous, iris, and ciliary body prolapse, hypothonic hyphema lens side resection, with a primary wound closure with pars plana vitrectomy and a lensectomy as a first attempt. Then in a second stage, I performed a valve Ahmed valve collocation, implant. And in the third stage surgery, I managed the aphakia nvidia of this patient. I performed two inverted Hoffman pockets. I always work with an anterior chamber maintainer. I do a demarcation 1.5 and 2 millimeters perpendicular to the limbus to do the lens fixation. I perform a scleral corneal groove or scleral corneal incision. This is a great size lens, so the incision is a big incision. This is a Gore-Tex suture. I do the sclerotomies with a 27 gauge trocaris, vitrectomy trocaris. So it does a very small sclerotomy, almost self-sealed. I pass the Gore-Tex suture through the hole of this Morcher lens. This is a aniridic Morcher lens. With a handshake technique, I pass the sutures through the sclerotomies. Then I prepare the lens. I enlarge the incision. Here can you see, I take the suture through the pocket Hoffman. The Hoffman pockets permit that the knots get buried below that pocket. When we have all prepared, then we proceed with the enlargement of the incision. It is a very large lens, so that is one of the cons of this lens, an iridic lens. Then we proceed with the routine watertight closure of the incision. This was one doubt I had if I leave the glaucoma tube below, under or on the prosthesis. When I leave it behind the prosthesis, the prosthesis gets tilted, so I change the tube and I put it between the iris and the lens. Then you can see the knots become very buried. This is the end of the case with very good result and very good restoration of vision. Thank you, and I hear any comments.
Thank you, Nicholas, for sharing. And any comments from the faculty?
Sir, what about the suture, the white colored suture? Which material
it is? A Gore-Tex. It is 8.0 Gore-Tex suture. It's from Gore-Tex. It's a very hard material.
Okay, sir. Thank you. And another question is, after so much manipulation, what are the how the tube was behaving post-operatively? For how many days the post-op IOP was controlled like that? Anything?
How many days? Pardon, please. Can you repeat the question?
Okay. After doing so much manipulation, the AGV valve, the being in the eye, how are the prognosis? How are the post-op IOP in long term? In this case,
the pressure,
intraocular pressure.
No, after we implanted the Ahmed valve, the pressure was controlled. That's why I always do a 2 or 3 stage surgery. First, I control the pressure, and then I implant the aniridic lens. I don't like to do all at the same time in one stage surgery. So when I have the pressure control, then I do the refractive surgery at the end.
Okay. Hola, Nico.
Sí.
Thank you.
Sudhi or Dr. Sudhi, have any comments, or Dr. Sarah?
Well, I think, sir, the availability of 80 Gore-Tex is a little bit of a problem in some parts of India. So you're really blessed that you have 80 Gore-Tex available with you. The Gore-Tex switches work very well with the Hoffman's pocket, much better than the Prolene ones. And for the IL stability, if the IL is so bulky as the moistures, as you exhibited, I think Gore-Tex is very good. But we do have availability issues, particularly with the 80. We have 70 that also is sparsely available in India, but 80 is really rare to find here. So I mean, yeah, very well managed, but yeah.
In this case, I think it's a good option. I used to do it with Prolene, but this is a very heavy. I think it's a heavy.
Exactly. Yeah, it does have tilt issues later on. True.
And it's the best option. I think it is Gore-Tex suture, and it's a long-lasting suture, and this is a healthy patient that has to continue working several more years. So I think this is a better option.
No, but a valid question here, Dr. Nicholas, it would be, if you're not constructing a Hoffman's pocket, say a surgeon is not constructing a Hoffman's pocket, would you on a scleral bed, on a bare scleral bed without a pocket, would you advise the use of Gore-Tex?
I don't like to leave. I see sometimes the Gore-Tex below the cones, and I don't like, because sometimes you can see the
erosion,
the white. No, you can see the white suture below aesthetic disturbance. No, you can see the suture when you see the face of the patient.
Yeah, it causes a hump. Right.
I always like to bury the knots, so with the Hoffman pocket, it's a very, or a scleral flap, it's the same, or the groove, a scleral groove also. You can hide the knots, but the Hoffman pocket, this is a variation of Hoffman pocket. The Hoffman pocket is parallel to the limbus.
From the limbus,
this
yes.
Is
an
inverted.
Right.
It's an inverted Hoffman pocket, but it's a nice surgery.
Thank you, Dr. Nicholas, for sharing your video. So next, I have the pleasure of introducing Dr. from Colombia, and I'll share my screen now. Dr. Hugo H. Campo is a retinal and ophthalmologist from Cali, Colombia, South America, and I had an interesting. I went to for Ecuador, Indians don't need a visa, which is unusual for the Indians, because otherwise every country asks for a visa, and Ecuador does not have. And I checked 10 times, and when I landed in Ecuador, I found there is no Indian embassy because of some issue between India and Ecuador. And then, even though you don't need it, but we have the embassy in Bogota in Colombia. Anyhow, and Dr. Hugo is Professor Universidad del Valle, Cali, Colombia, and former president of Colombian Association of Retina and Vitreous, ECOR. And actually, they invited me for ECOR. Somehow it was clashing. 2020, I'll go there. And former president of Pan American Association of Ocular Trauma. And he's also my colleague and board member in the International Society of Optical Trauma. So after you, Dr. Hugo, you can show your video. And next, I'll ask Dr. Hudson after you.
Thank you, Natarajan, for the kind invitation. Good evening for the India, good morning in America. I'd like to show you this short video about the importance of the take very carefully with the clinical history in the patient with ocular trauma. Do you see the video? Okay. This is a patient of 27 years old. He was wounded with a screwdriver in a fight in the jail, and the visual acuity initially in the service was light perception with a severe vitreous hemorrhage and a little scleral wound in the superior glove. So we here in Cali, Colombia, in the Universidad del Valle, used to be the whole surgery in one time. I mean, close the wound and make the pars plana vitrectomy in one time. We don't prefer to wait 2 weeks. And this is a beautiful example why this is a good choice in some moments. Okay, this is the case. This is the eye of the patient. And the first is look the aspect of the eye. You can see an apparently good aspect of the globe. And you can see here the wound in the superior part of the sclera. We made the suture with Bimanual 70, like normally we do. And maybe you could stop the surgery here and wait for 2 weeks for the next surgery, but we always used to be the complete surgery. So we made 2 lumbar incisions and put a maintainer chamber with cannula, clean all the fibrin. You can see the intraocular lens previously in malposition, but this is before the trauma. So once we have this maintainer, we prefer delay the pupil with a mechanical delayers in order to see the best possible the retina. With a 23-year gauge, we start the pars plana vitrectomy. You can see a severe vitreous hemorrhage, but I want to see in this part. You can see a little chemosis in the inferior part of the globe. You can see the severe vitreous hemorrhage, but the posterior pole was okay. We are clean of the periphery of the patient. But look here, this chemosis is a little progressive chemosis in the inferior part. And in more time we do the surgery, look, the chemosis is grow up. So this is a clinical sign of perforating injury. So we need to complete the peritomy. And you can see here the second wound here. So we proceed to close this wound with Bimanual again, 70. And after that, complete the vitrectomy. So this is an important part of the surgery, is looking what happened to the eye during the surgery. Once one close the wound, we will finish the surgery, but you have 2 intraocular foreign bodies. This is the number 1. This is the number 2. I will take out the second intraocular foreign body. It's here. This is the trophy over the cornea. And after that, we complete the vitrectomy and close the eye. So the message here in this little video is the importance of check the glove during the surgery, and we always recommend our resident to do the complete peritomy exploratory in ocular trauma, even if you don't think it's very probably perforant injury. Okay, this is the fine of the, this is the one wound, 8 millimeters, and the second one in 7 millimeters. Are we finished to share? And thank you.
Thank you, Hugo, for showing us wonderful as always. And I think you're a great vitreoretinal surgeon and trauma surgeon from South America, supporting the whole world. And Nemesis, I would like you to.
Well, just for Hugo in the beginning. It was a great presentation.
Thank you.
And I really like the way he put it. And I'm looking forward, Hugo, for your next work that I would gladly participate. It was nice hearing you again.
Thank you, Atanasio. Thank you very much.
Professor.
Yes, so I know Hugo has actually made another beautiful conference where I already given my recording, and one more, not one more, I think one more in I think Mexico they are doing a meeting, and I'm glad. I think I've taken part in the lot of South American webinars, and I'm happy. One day maybe I'll come and settle there. I would have a choice between Greece and either Colombia or Brazil or Argentina or maybe Chile.
Yeah.
So, anybody? Dr. Hello,
Hi,
can
Hugo.
Yeah, Hudson, how are you?
Yeah, thanks. I'm fine. I liked your case a lot. You know, I like doing the 360-degree peritomy to try to search for any tear or scleral tear. As you said, in this case, you had these chemosis, and it's a good stuff. It's a good thing to do, you know, 360 conjunctival peritomy, so that you search for any other leak, any other lesion. And that was a great work. I loved your surgery. Beautiful, beautiful.
Yeah, thank you. Yeah, I mean, you take 1 minute to complete the vitrectomy, but you will be sure that you don't have another wound. This is the idea.
Dr. Alok and Dr. Santosh.
Yeah, I think the point was very well set across, that you need to open up the conjunctiva 360 degree to look for any occult perforation. That's very important in any trauma where you suspect occult perforation. So as rightly pointed out, there could be more than one site of perforation, although rare, but still you can have very, very nice videos. Very nice.
Thank you. Thank you, Doctor.
Thank you, Hugo, for being a part of us today. Like we have 6 continents, 12 countries taking part, and I'm happy. Even though I can't travel, I made everybody come here. So now I have a final speaker, that Hudson, and we have his video. And Hudson, I just wrote in your retina with his friends, I love you.
Yeah, thank you very much, Natarajan. And I'm here back again. And with this case, this is such a nice case that we showed in some other webinars as well. We'll be sharing the screen here. And I invite you once more for our meeting next Saturday. It's the Retinal. We have it down here at the Retinal channel. And this is a case of severe intraocular foreign body. As you can see, the patient had this severe gunshot injury with intraocular foreign body. And you have the corneal path and the lesion at the cornea. And you see here, you can actually locate the 2 intraocular foreign bodies there in the eye, and you have the CTs, and we were pretty sure there were 2 intraocular foreign bodies, and the B scan shows their location. One is in the mid-vitreous, another one is stuck at the retinal periphery, at the choroid, and the rhexis was pretty hard because you know, there were so many adhesions, and also you see here the posterior capsule rupture. The vitreous very adherent. It was tough to remove the vitreous, very adherent, and it took me 15-20 minutes to remove the cortical vitreous, and you see the site of the perforation there. And now the foreign body is floating around the vitreous. With the crocodile 23 gauge forceps, I could easily grab it, the smaller one, and I enlarged the sclerotomy. I put the foreign body over the cornea there, and we went ahead now. And the second foreign body was a larger one, was stuck at the choroid, and we removed with the same forceps, as you can see. we had this great wide-angle visualization system. So even though the foreign body was irregular, I could grab it and I had to enlarge the sclerotum a bit more. And it was stuck at the scleral wall, but still we could remove it, and it's a quite large one. And after that, we noticed the retina was detached at the very periphery. We used a perfluorocarbon liquid to push the retina back to the original position, and doing some laser. We did a 360-degree laser because the retina was detached there, but the macula was okay, and the macula kept attached all the time, and it's still attached. It's over 3 months period post-operative. Removed the perfluorocarbon liquid, and we did laser at the end of the case, and ended well, and results, and the macula is pretty good, and the patient's happy, and maybe not far from now we're gonna do this secondary intraocular lens implantation. Thanks. So the reason we did this vitrectomy, we did not take too long to do the vitrectomy because the macula was spared, and metal inside the eye, and it was from the gunshot. We could easily have this BI, the infection, the compensation, and everything, and the best thing was to remove it, and in due time. We cannot take too long, and we fixed the retina afterwards.
What about chorioretinectomy? What do you think about the idea? Like Ferenc used to teach us, that when you see that foreign bodies at the end, you should remove everything but the sclera around the wound exit.
Yeah, I've performed some cases of trauma where I did choroidectomy actually, and the thing is, this foreign body was stuck at the choroid in the far periphery, but we removed the foreign body. The retina was stable. What I did there was a retinotomy, very peripheral retinotomy. And so the choroid was not detached, even though the foreign body was stuck in there, but it was not detached. So with the PFO, I could easily put everything back at the very retinal periphery. So I did not do, I did not need to do much choroidectomy, but I've performed some choroidectomies in some cases to remove the foreign bodies and to get rid of these damaged choroid, and you have to do that. And I finished the cases with laser, and in those cases, I always use silicone oil. Otherwise, gas, in my experience, would probably do, the milieu for infection and these things, and the retina could detach again, and with the silicone oil, it becomes stable. So that was a pretty good case with a good outcome. We are just waiting a bit to remove the silicone oil.
Dr. Hudson, a wonderful video, and I must congratulate you. And I share Dr. Athanasius' views that once the foreign body is embedded in the retina or choroid, the rate of PVR rises exponentially, sometimes to 70–75%. So there is a very valid point in our Dr. Ferenc Kuhn's observations of doing a chorioretinectomy. I limit my chorioretinectomies in foreign bodies embedded to little, I mean, around the macular area. So that's where I suspect a post-operative ERM formation later on, or macular resulting in drag. So to prevent that, those PVRs, posterior pole PVRs near the macula, I limit my chorioretinomies to. But like you said, not for peripheral.
Yeah, okay. And also at the macular area where we had the intraocular foreign body stuck, we had that lesion. So, you know, I preferred doing only laser because it was clean. And I removed the foreign body there. And I like the idea. Some people like doing even ILM peeling for these trauma. The results were good, and the patient still with no PVR, nothing, and it's stable, completely stable. So I didn't think it was necessary to remove the ILM or to do the choroidectomy at that place. But it's a good idea to prevent, and also the patient kept some time after the surgery on PO medication, corticoids, and everything trying to inhibit this PVR formation.
Have you tried installing Ozurdex implants in these cases just to prevent, as a sort of preventing PVRs?
Yeah, good
Even
idea.
with silicone
I
oil.
never tried that, but good idea, good idea. You know what I do? I insert corticoid, half and half BSS, half corticoid inside the eye, so that always also prevents inflammation and PVR. That's a good idea too.
Dr. Ayal, may I?
Yes, you go.
Okay,
Yes.
thank you. This technique, I mean, we use here to the chororetinectomy prophylactomy, but there are two concepts here. This is the prophylactic chororetinectomy. This is the technique that you use in the first surgery. This can avoid many PVR cases, but if you have a PVR case after a surgery, you can use the technique too. I mean, you can use the retinectomy and cut all this retina, this choroid, and leave the sclera nude. This is a very good technique, and here in Cali, you use this technique too.
Yes. So thank you all. And Sabyasachi, should I do my last presentation? Be there out of Subudhi?
No, yes, sir. It is our pleasure to have you at the beginning, at the end also.
Just we are wondering about your energy.
Yeah, that is the energy of a green chili.
Yes. When I did the trauma meeting, Mayur Shah supplied every 1 hour chilies. So I'm having in when I'm moderating.
So seeing you, it appears as if we are going to start the program, not end the program.
Thank you, Dr. Natarajan. Thank you.
Thank you
I
all.
thank all the speakers on behalf of OS.
I'm actually showing the one last part of the. I want to thank
Thank you all.
Dr. Subudhi and Dr. Surendra, Dr. Grover, from and we have finally the
Sir, may I request these people to be a member of OTSI, sir?
Sure. We invite everybody from the world, including.
Sure, Dr. Mahalji, sure.
Yes.
Thank you, sir.
Yeah.
1 second. Should I show my video last part?
Yeah. Please carry on.
Sir, please go ahead, sir. Please.
We are waiting for that.
So this is on a corneal tear and traumatic endophthalmitis. So that's the team we have, and they all Lakshmi is here, who's the one who did the whole program. Lakshmi originally worked with me in 2003. Now I'm training her as a retina fellow, so that one day she can give my talks. And this is a video where Dr. Kavita Rao helped me to do this eye was almost like with the trauma happened 10 days earlier, and then the patient came after primary repair. We planned for a PK with the temporary cataract process with the PK again. But unfortunately, when you opened, we saw it was terrible. We did a clearing of all the exudative material from the surface of the eye. And repeatedly, I remember Dr. Kavita Rao asking me, is it worth operating? But I think the idea was to show here, it's easy to give up. But I think if the eye is still in endophthalmitis stage, not gone into the panophthalmitis, I think we can save the eye. And corneal graft, but I think if we can preserve the eye, nothing like it, particularly when you're 10 years old. Even if the eye becomes bicycle, I think it's worthwhile. And this is another. And here we have removed again. Temporary prosthesis, and I'm using the ACAT cataract made in India, and exudates were there, so I use the 20 gauge and also 20 gauge to remove the material. And it looked like it was a terrible eye. The eye may be lost, but you can see there is a good. You can see the entire vitreous is cleared. You can see the optic disc, and then we did the corneal graft, and Dr. Kavita Rao did the corneal graft. I do the back part. So we don't give up. I think right from front to back, we repair the eye and make sure that the patient gets something. This is a final video, which is actually from experience with Kashmir. Again, you can see the corneal sutures here. This was the pellet ocular trauma, where the pellet had entered through the cornea, luckily not in the center, to the side, produced traumatic cataract, traumatic vitreous hemorrhage, submacular hemorrhage, and the pellet went through and through into the orbit. So here again, Dr. Kavita Rao is doing the phaco. I hope Kavita is there in the group, so she can comment, and doing the phaco aspiration. You're a young 30-year-old. He was doing his PhD, and there was a range of 5 to 15 years were the maximum. Sorry, 15 to 21 years was the maximum people injured. I think we had 1,700 injuries, ocular injuries with pellet, and you can see the cataract done, and then the intraocular lens implanted, and then now I'm going ahead with the 23 gauge. And we do nowadays a secondary intervention in 1 week. So you can see the submacular hemorrhage also is fresh. And at present, I'm injecting the perfluorocarb liquid, please do the submacular hemorrhage, and then that we made a tiny retinotomy using a 39 gauge needle, which is used for going to the to do the subretinal blood. And then to find once the retina is attached, I actually make sure to the fine retinotomy that endolaser was done. And our idea was to remove the blood from the macular region and use silicone oil as a tamponade. So I think my topic is salvaging the unsalvageable, and I wanted to tell because trauma unfortunately keeps happening all the time in spite of all the prevention from our trauma group, and we have to do that. And I think and this is again, I just want to show a quick how important it is to do a meticulous wound repair, and this I did it myself. You can see a irregular corneal tear extending to sclera to make sure that the limbus end to end is first secured, and then you can see in between central corneal suture. And I think it's tricky to do a airtight, watertight suturing, and then you expose from the limbus to posteriorly and make sure that you don't extrude the intraocular contents. And I wanted to say that even after so much of experience, this is my 30th year in as a vitreoretinal surgeon and ophthalmology, and I love to do primary wound repair whenever there is a chance. But if Dr. Kavita is there, and she does the corneal wound repair. And I just wanted to say that it takes time to do a meticulous wound repair. Sometimes it takes hours. You can see the meticulous wound, and finally the conjunctival closure done. And many times I like to do it myself just to make sure that because primary wound repair done well, there is a chance of second surgery done excellently. So thank you very much for the opportunity, and thank you all.
Yes.
And probably give her comments because she's my savior as a corneal surgeon working with me, and we do a teamwork. And Kavita, are you there?
I'm there.
Pardon? Are you there?
Yes, yes, I'm there, sir. Can you hear me?
On cornea and vitreoretinal surgery. Kavita?
Yes, sir, I'm there. Can you hear me, sir?
Yeah, now we can hear. Yes, yes. No, are you able? No, we can't hear you, Kavita. Kavita?
Yes, sir, can you hear me now? I think there is one question in the chat about using a Fleringer ring. So,
yes.
Definitely, when you're doing an open globe, a Fleringer ring is a must. Sometimes, if there's too much of chemosis and, you're not able to get a placement, then, like in that particular case, I had tried putting a Fleringer ring initially. Ideally, you should be putting a Fleringer ring in all cases, but when you also have to make the 3 ports, which sir needs to make those ports, it's sometimes difficult to, space all of that in the eye. I did go ahead with just putting the temporary K-Pro first, and I did not find that so difficult.
And Hudson has asked a question, how you avoid low pressure or globe collapse? We already answered by saying we first place the intraocular, the ports first, and then start the infusion. Hudson, you want to ask that?
Yeah, I'm here.
Yes.
I heard of the Fleringer ring, but to keep the eye stable, and you cannot actually take too long to put the graft or either the keratoprosthesis. And you said you have this India-made keratoprosthesis, and maybe easier to stitch it on the cornea. Can you tell me about that?
So Kavita can say she does the stitching of the temporary keratoprosthesis to after taking the infected cornea. Kavita? About how stitching the temporary keratoprosthesis.
After you excise, just like you're stitching your graft, this is like a plastic ring which is available. You can suture it using either, what I use is Vicryl, that works pretty well. 60 Vicryl, that works well, and you take 4 sutures and it gives good apposition. I've never had any issue with not being able to oppose.
So the entire idea is to save the eyes first anatomically, and then functionally we can see. Sometimes we may have to do second graft because the cornea becomes opaque, and sometimes she just showed her own case where the graft was okay, but she came with a non-trauma with a cataract. Thanasis, you want to say something?
One question, Dr.
Thank you.
Natalia.
Yes.
Do you use what kind of anesthesia do you perform? Use the anesthesia. What is it in these open globe cases?
Nicholas, can you repeat?
Yes. What kind of anesthesia you use in these open globe surgeries? General anesthesia or local?
In the beginning, when Thanasis visited me, I used to do general anesthesia. And now we are doing local anesthesia by giving a Van Lintz block. And the second is we are giving for the upper lid and lower lid first, so that the patient doesn't squeeze the eye. And my anesthetist is very good. He gives some sedation where for a few minutes the patient is sleeping. He doesn't realize that when the local is given. And if it is open globe, definitely we have to keep that mind that intraocular content should not come out. So usually we give a Van Lintz block, and after that, through like a peribulbar, through the conjunctiva we give so that we don't increase the intraocular pressure. So local anesthesia, it's like a regional anesthesia in a different way, so that we don't like a regular peribulbar we don't give, but on the table under the microscope after the draping, I think the surgeon gives. Kavita, you want to add anything on that? Because we do under local, except the child.
And do you use mannitol?
Mannitol, no. Because it's already an open globe, so no. Only when not.
I think more. I think
The
more or less
infection, you have an infection, so mannitol isn't a good option. With an infection, I think it isn't a good option.
Okay. Good option. Yes, then
no, it isn't a good option.
I think now you have much more control on the intraocular pressure than before. We were afraid of doing local because we thought that if you used subtenon anesthesia, you might increase the pressure outside the eye, and you might do some subocular hemorrhage, and then it's going to complicate the whole thing. But now things are completely different, and we can control with the infusion and all these tricks you have. But also seeing you operating there, it reminded me that was the strongest image I had from Cesare. I think that it's like seeing Cesare doing a pole-to-pole surgery. So we're still the same fans of pole-to-pole surgery you can do from cornea to the posterior pole. And it was a good memory. But with such a huge experience, I still remember suturing the tongue of the patient.
Yes.
Don't explain that.
Sir, Natarajan sir?
Yes.
Sir, thank you for your wonderful 2 cases. But I want sometimes you also do with facial block and some periorbital block. But I think the message should go to the house that if the general anesthesia is available, we always should do under general anesthesia for open globe injury for a better particular meticulous fine surgery. What I think, your view?
No, that's because of the excellent anesthetists we have. He's also active member of the Ophthalmic Anesthesia Society in the world also and in India, Dr. Sharma, and that's what we do. But otherwise, definitely I prefer the general anesthesia. And I think because we are specialized in working on local, we are, and as you rightly said, no trauma to the eye. Already the eye is traumatized. So you have to make sure that, as Dr. Thanas has said, and you are saying, the message to the whole world is that make sure that you don't disturb the eye. And that's why Dr. Nicholas added, you should add the mannitol. The idea is not to have any erasing the intraocular pressure or getting the contents out, because having an expulsive is the worst thing to have, or getting the intraocular contents out. So good.
Yes,
and I think one of the child open sky vitrectomy I did was under general anesthesia, because that was a child, 10-year-old child. And I think like
I remember one thing that we used to hear a lot was a prophylactic buckle beforehand, to put a prophylactic buckle when you have a trauma beyond 8 millimeters, 12 millimeters. If it's inferior, you have to put a prophylactic buckle. I think nobody says anything about it because it was more traumatizing to the eye than the trauma itself. Try to put a buckle pulling. And I hope that nobody's going to talk about it anymore.
Right.
Yeah, in selected cases, Dr. Athanasios, I remember when I did my retinal fellowship in Toronto, Canada years ago, we did this vitrectomy, but for trauma cases. But after we sutured the sclera, and then we passed, we encircled the eye with the 240 band without tightening it, just for support. So the eye had the already closed.
I don't think it's supporting. It's just a voodoo. It's just something that you believe. It doesn't really work. And I remember Zivonovich used to say and ask him why you put a buckle in every vitrectomy case. He said, because I cannot see the periphery. They used to put buckles in order to get the periphery to the view of a 30 degrees contact lenses. Now you have 120 degrees non-contact lenses. You don't need to have a buckle to get in. And then when you still use it, and I said, now you have a non-contact viewing system, he said, now it's a voodoo. It's something that I had to do before I do my surgery. But honestly, there are cases for this. There are cases. But not to every case that is beyond 8 or 10 millimeters to put a prophylactic buckle while the sclera is open. That's the issue. because some people used to start with a buckle and they pull the muscles, and they don't know if there's opening behind the opening they have. You have a beautiful video from Colombia saying that you can have two sides instead of one. So if you just suture one and then you put a buckle, you're squeezing the other one, and you make a incarceration of the retina. That's sorry for my passion on that, but I've been through very difficult situation myself. Anyway, thank you. It's beautiful to present.
Thank you, Thanasis. And I think any good program has to come to an end. And thank you very much. So I now thank all my friends from all over the world here, and everybody I think has done wonderful, and I've learned a lot. And special thanks to Thanasis, because
I'm not a friend anymore. Not a friend anymore. I have to remember that. You are my brother now. You are my Santan brother.
Okay.
Okay.
Santan.
Younger brother.
But you know, Thanasis, I don't want to tell you. I thought I should call you like the father and son.
Yeah, exactly. Although we are the same age, always when they see us together, they say, "Hi, you have your son here?" I say, "Yeah."
Great. Thank you, Thanasis, and thank you all.
Well, we must thank Dr. Natarajan. So let us give a clap. So let us give a clap to Dr. Natarajan for successful.
Yeah.
Thank you. So, we will
Thank you, sir.
with Dr. Nageshwar Rao from Odisha State Ophthalmic Society and Dr. Das to give the thanks. But from my side, I want to thank Raman and all the people in Entod, particularly Rahul, and especially Lakshmi, who was really coordinated very well and made it well. And when my own telephone conked, and I'm happy she did everything.
Yes.
Thank you, sir. Thank you, sir. Thank you, sir. Thank you, sir. With all your efforts only.
Team and Ento team, sir.
Yeah. Yes.
Thank you.
Thank you, everybody.
Nageshwar, you are telling okay. Yeah. And Subhadip, maybe you and Nageshwar Rao can conclude the session.
Yeah.
Sir.
Thank you, everybody.
Let me go and swim. Enough, thank you. Let me go to swim now.
Yes.
I'm next to the sea, and I just look at it.
Thank you all.
You're invited to come. No more webinars. Bye-bye.
Nice day to the rest of the world. Have a nice evening to this part of the world.
Thank you for the invitation and for the organization. Very good. Thank you.
Thank you.
See you Retinal next week. Bye
Yes.
bye.
Thank you.
Bye.
Yes. And you can stop the recording.